2, 1. We are live, sir. Please start.
Yeah. Good evening, all. On behalf of the organizing committee, I warmly welcome all my dear faculty colleagues, participants in the today's virtual conference. So today's program is mainly aimed at bringing and bridging the gap between what we practice and what the evidence says. I'm confident that the discussion will be based on more of evidence and our day-to-day practice. And at the end, we take some practice changing points, and it will help each other in managing the difficult cases. I thank all the esteemed speakers who have joined, and I also thank for the sponsorship, the gender support by Zydus, AstraZeneca, Roche, Glenmark, Eisai, and Adley. So, with this, without much ado, we will start the session and we'll proceed with the proceedings. Thank you.
For the first talk, I would like to invite Dr. Sai Vivek on the topic immuno-oncology in motion in tislelizumab promise in esophageal carcinoma.
Yeah, thank you. And at the outset, I would like to thank the organizers for this opportunity. I think, yeah, as I share my screen, I hope my screen is visible and I'm clearly audible.
Yes, sir,
Yes,
you
sir.
are.
Yeah, so this is a sponsored session, and the topic given to me is immuno-oncology in motion, tislelizumab, the promise in esophageal squamous cell carcinomas, esophageal GE junction, and gastric cancers. So I think we'll start off with esophageal cancer. We'll talk about squamous cell carcinoma of the esophagus in the first line setting, the advanced first line setting, and the second line setting. What is the current data that we have, and how tislelizumab is actually giving us another very good option to use in our patients, especially in the resource constrained settings like our country. So, esophagus amongst males is the third most common cancer. More than the incidence, what is really scary about a squamous cell esophageal cancer is the high mortality rates. So, when you diagnose a person with esophageal squamous cell carcinoma, we know that majority of the patients, almost 40%, are diagnosed in advanced stages. And for advanced stages, the 5-year overall survival is in single digits and is around 3 to 6%. Even if you diagnose them in early stages, there is a high chance of recurrence when we talk about the squamous cell carcinoma of the esophagus. And we all know that because of the usage of tobacco and other products, the incidence and mortality are higher in men compared to women in our country. So anatomically, we know esophagus is divided into cervical, upper mediastinal, middle mediastinal, lower mediastinal, and the G junction, and that leads to the stomach following that. So 85% of all esophageal cancers are squamous cells, but this percentage does vary. Now we are seeing a lot of adeno also in the G junction, especially in the wake of the rise in obesity and lack of physical activity. So typically, it is the squamous cell carcinoma is located in the upper middle third of the esophagus, seen in patients of the fifth and sixth decade. And then, as we saw before, it carries a very poor prognosis. Adenocarcinoma constitutes 14% of all esophageal cancer worldwide, mainly localized to the lower third of the esophagus, seen in a decade older patients, that is, the median age is around 64. Relatively, it has a better prognosis. But still, overall, when you compare it to other cancers, all cancers of the esophagus carry a poor prognosis. So if you look at the trial data for tislelizumab, let's do that first, and then we'll do a cross-trial comparison, though it's not really the correct way to do it. We'll see what are the options available to the clinician in the clinic when we encounter patients with advanced esophageal squamous cell carcinoma. So Rationale 306 was phase 3 randomized multi-centric international study where patients were enrolled from multiple countries, as we see on this particular slide. So Here, the patients were included if they had unresectable, locally advanced, or metastatic esophageal squamous cell carcinoma with no prior systemic treatment, ECOG PS of 0 or 1, and they were randomized into a 1:1 fashion, 326 patients in each arm, to tislelizumab plus investigator-chosen chemotherapy. The two options here, or the main regimens that were chosen here by the investigators, were CDDP5FU, that is platinum plus fluoropyrimidine, which most of us still do use. Another easier option again was platinum plus paclitaxel. It could be paclitaxel, cisplatin, or carboplatin. In squamous, we all tend to move a little bit towards the cisplatinum compared to carboplatin. The placebo arm was just investigator-chosen chemotherapy, and patients were stratified into PDL1 TAP score of more than 10% and less than 10%. But we have enough data to say that the tumor area positivity, or TAP score, does concord with our PDL1 that we use with both the platforms, either the Ventana or the Darko. You can interchange that as PDL1, the TAP score, to the normal PDL1 that we get in our labs. So the primary endpoint here was the gold standard overall survival and multiple secondary endpoints, including PFS, ORR, and duration of response. So once we go through the primary endpoint data, we can clearly see an early and continued separation of the overall survival curves. The curves separate as early as 2 to 3 months, and the curves do widen with time. And with immunotherapy, we know a fraction of patients who do respond tend to benefit in the longer duration of time. So the median overall survival here was definitely 17.2 months versus 10.6 months, with a good delta of 6.6 months, or half a year. Half a year of additional overall survival was given by this particular combination of tislelizumab plus chemotherapy. That translated into a statistically significant p-value and a hazard ratio of 0.66. So the primary endpoint was met. It was statistically significant and clinically meaningful also. So the secondary endpoint, PFS, again, if you look at the PFS curves, we can see a separation of early and maintained separation of the PFS curves. The 12-month PFS was doubled at 15.7 months in the comparator arm versus 30% in the treatment arm. The median PFS was 7.3 versus 5.6 months, again with a very impressive p-value and a hazard ratio of 0.62. So when we talk about immunotherapy, the duration of response also is something that we talk about. The patients who do respond tend to have a sustained response in majority of the cancers. Here, 5% of the cancer patients had a complete remission, and around 60% had a partial response. So impressive response rates, especially with esophageal carcinoma, where dysphagia is the primary symptom. Patients do look for the symptomatic relief, so we need to have a combination which does alleviate the symptoms too. So the adverse events with the usage of chemoimmunotherapy in multiple other cancers, we know that the rare side effects of immunotherapy can be managed with prior counseling and a high degree of clinical suspicion and periodic testing. So if you look at both the arms had almost similar grade 3 or more adverse events, and patients with more than one treatment associated adverse events were also quite similar. So if you just look at the immune mediated, around 21% of them had immune mediated side effect, with less than 10% of them having grade 3 or more adverse events. So that gives us a good option for the first line setting. So if we haven't used the combination of chemo plus tislelizumab in the first line setting, we have the data from Rationale 302, where tislelizumab monotherapy was compared with second line chemotherapy in patients who have progressed on the first line treatment. Here, the patient should have received any of the first line treatments, and patients were randomized into tislelizumab versus investigator chosen chemotherapy, either paclitaxel, IVQ 3 weekly or weekly, or docetaxel or irinotecan were the three drugs that were used in the comparator arm. So the primary overall survival again here was overall survival in all randomized patients. Secondary endpoint was overall survival in patients with a TAP score of more than 10%. So stratification was again done based on the TAP scoring. So here again we see in the overall survival curves on the right-hand side of the slide that at 12 months, the overall survival was 37.4% versus 23.7%. So, which translated to a hazard ratio of 0.7 and a statistically significant p-value. So, again, we do see that separation of curves is early and it is maintained. So, there is definitely a benefit with the usage of immunotherapy, that is tislelizumab in the second line setting, while compared to investigator chosen chemotherapy. This gap widens if you look at the subgroup of patients with a TAP score of more than 10%. The median overall survival is 10 months, 10.3 months versus 6.8 months. The hazard ratio gets even better at 0.54. So I think without doubt, tislelizumab does become the valuable second line option. So the additional overall survival benefit is around 3.5 months. So these are the secondary endpoints. Even if you look at the 12-month PFS rates, it's 1.9% versus 12.7%. So definitely having a benefit in terms of what we can see in the curves, but statistically not significant again because the confidence interval crosses 1. So PFS not reached, but overall survival was met in the second line setting. So tislelizumab demonstrated a tolerable safety profile. This is just immunotherapy, no chemotherapy. So if you look at the treatment-related adverse events leading to discontinuation, they are in single digits in the immunotherapy arm at 6.7% compared to almost double in the chemotherapy arm. So even in terms of quality of life, single agent tislelizumab is easy to administer, and all of us do agree that the patient do not have major adverse events. So these are all the studies that we have available in the first line setting in the esophageal squamous cell carcinomas. We are all using, I think, the different immunotherapy molecules. So if you just draw attention to the median overall survival, which is the gold standard for most of us, most of them are quite similar. And tislelizumab numerically does have a certain benefit, but this definitely is not the way to compare different trials. But we can at least be rest assured that compared to what we already have and what we have already used, this particular agent is definitely not inferior. The superiority we can never know because there'll never be a head-on-head trial. So even in the second line setting, again, we have the 3 trials that we are looking at the results. So the median overall survival is quite similar amongst all the 3 trials. And so tislelizumab could be definitely used in the second line setting also. Moving on last to the gastric cancer or the GE junction adenocarcinomas also. So here we see stomach cancer is again, the incidence is fifth amongst males in our country, and it also carries a high degree or high incidence, high mortality rates in our particular country because of the diagnosis being in advanced stages. So the gastric cancer has 2 major histologic subtypes. We know the intestinal adenocarcinomas or the diffuse adenocarcinomas or the Linitis plasticus, so which are even more aggressive. And this particular cancer usually does not give us time to even go to the second line setting. And almost 30 to 40% of our patients do not have the performance status to receive a second line regimen. So using the most effective regimen in the first line setting is even more important when we talk about the gastric cancer or the GE junction cancers. So in the rational trial that we are looking at here, so patients with HER2 negative disease who hadn't received any prior treatment for GE junction or gastric cancers with an ECOG PS of 1 or less were randomized to tislelizumab plus oxaliplatin capecitabine, or that is Xelox or cisplatin 5-FU plus tislelizumab in the treatment arm versus placebo plus Xelox or cisplatin 5-FU in the comparator arm. So the primary endpoint again was overall survival in PDL1 positive, that is more than 5%, and the intention to treat analysis subset. So the key secondary endpoints for PFS, overall response rates, and duration of response. So when we look at the results from this trial, before that, if you look at both the arms, most of the parameters were well balanced amongst the 2 arms. Most of them had a stomach cancer, and most of them had a the PDL1 less than 5 to more than 5% also were well balanced, and majority of the patients had the usage of capecitabine plus oxaliplatin, as is what we use in our clinical practice in our country. So the Kaplan-Meier curves of overall survival at 3 years. So if left hand side is the ITT population and the right hand side is the PDL1 TAP score of more than 5%. So in the intention to treat population, the overall survival, again, as we can see, the curves are separating. The hazard ratio is 0.79 and the confidence interval is 0.69 to 0.9, does not cross the unity mark. So the median overall survival is 15 months versus 12.9 months. So in patients with PDL1 more than 5% or equivalent to 5%, the hazard ratio gets better at 0.71, and the median overall survival is almost 16.4 months versus 12.8 months, a delta of nearly 4 months. So the PFS curves also again are separating. And here we see the PFS numerically, the magnitude of benefit is lesser at 6.9 versus 6.2 months, but the hazard ratio is 0.78. So the tumor response rates again are better with immunotherapy plus chemo at 47.3% versus 40.5%. So in terms of overall survival, in terms of PFS, and in terms of response rates, again, the combination of tislelizumab plus chemotherapy was superior. So the treatment-related adverse events causing discontinuation of treatment, again, were slightly higher in the treatment arm at 16.1 versus 8.1 percentage. And any immune-mediated adverse events were 30 versus 11. We can't compare this because immunotherapy was there in only one arm, and treatment-related adverse events related to death were similar in both the arms. So with immunotherapy, I think we no longer do look for the adverse reaction profile, because all of us are now well versed with management of immunotherapy related adverse events. So here, if you look at the other trials that are used to treat the patients, we have the pembrolizumab plus chemotherapy versus chemotherapy, that is the Keynote 407, and the Checkmate 649, that is nivolumab plus chemotherapy, which is also approved in our country. If you look at the median overall survival, all of them are quite similar, and including the median PFS. So we know that we have another option in terms of treatment, even in gastric cancer and gastroesophageal junction cancers. To summarize, we have seen the data set for esophageal squamous cell carcinoma first line, esophageal squamous cell carcinoma second line, and the first line in gastric cancer and GE junction cancers. Tislelizumab plus chemotherapy did have a benefit in the first line setting, and tislelizumab monotherapy, we did see a benefit in the second line esophageal squamous cell carcinoma. So that would be my last slide. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Vishnu Sarthi, consultant medical oncologist at Hospital in Bengaluru, on the topic of transforming patient outcome with the newer innovation therapy in first line advanced in SCC. Dr. Vishnu.
Yeah. Hello. Thank you. Thank you for the opportunity. I'll just share my screen. Hope my slides are visible. Hello.
Yes, yes, visible.
Yes, sir.
Hello. Hope my slides are visible. Yeah. So first of all, thank you to the organizers. Thank you, Dr. Ravi sir, for the opportunity. I'll just be briefly going through how HCC treatment has evolved and how immunotherapy has become now a cornerstone in HCC treatment. Coming to HCC, liver cancer is the 7th most common cancer and the 4th most frequent cause of cancer-related deaths as per the Globocan data. And it is now it is now become rapidly rising due to NASH and NAFLD, and it is soon going to become a very leading cause of cancer mortality. In almost 45% of the cases at diagnosis, the liver cancer is already spread beyond the liver to either lymph nodes or there's a major vascular invasion. So the prognosis outcome is poor, and hence the need for better systemic treatment, which has lesser side effects, more targeted towards the tumor and improves survival. So if you see the stage at diagnosis, we see almost 45% of the patients, the disease is pretty advanced, and the localized is only hardly 1/3 of the patients, and the 5-year survival rapidly declines based on whether it's localized or distant. We see even in localized patients, 31% of them have 5-year survival compared to just 2.5% to distant metastasis or a distant spread. So in coming to Indian data, India is the 11th most cancer type and 8th most common cancer related death, with HCC being the second most common cancer death in men, which is a very alarming statistic. This is because it is detected late, and now with the lifestyle changes, we see that a lot of HCC patients are non-viral and non-alcoholic related, which we commonly say as NASH or NAFLD, and we are seeing a lot of patients coming with advanced HCC due to this particular etiology. So in India, the incidence around 38,000 and deaths are around 37,000, with male to female ratio of 4:1, and it is mainly towards the middle age group 40 to 60, and the frequency increases with increase in age. In cirrhotics, almost 1.5 to 2%, 2% of all cirrhotics eventually end up with hepatocellular carcinoma. So in 50, almost half of the patients are in advanced stage in BCLC C and D, where local therapy is of not much use, and we are relying on the systemic therapy for the treatment. So the basic pathophysiology we do know in HCC, the main common etiologies are, of course, the hepatitis B and hepatitis C infections, more commonly seen in the Southeast Asian countries. We and the West are seeing more increase in the metabolic syndrome due to NASH and NAFLD, and of course chronic alcoholic abuse. The basic pathophysiology is inflammation driven because of dysregulated immune network. They cause immune suppression, exhaustion, there is missing tumor surveillance, and of course angiogenesis and proliferation. All of this where they escape apoptosis, escape the immune system, leading to fibrosis, cirrhosis, and quite a few proportion of them may also end up with HCC. The main immune escape mechanisms which we do know of are the overexpression of CTLA4 and PDL1, and of course the inhibition of antigen presentation, which is the main way how the tumor evades immune recognition. So the risk factors, pathogenesis, as we have seen, viral is still a good important factor, but it is the incidence of viral hepatitis leading to HCC is coming down. Substance abuse, again alcohol, though it is still significant, but we are recently seeing an increase in metabolic causes like NASH, obesity, NAFLD, diabetes causing fatty liver and steatosis, inflammation, and chronic inflammation also leading to HCC. In fact, around 20% of them may not even have background cirrhosis, and it can directly go, due to the inflammation, go on to HCC. And of course, male sex, geography, and other autoimmune hepatitis, which form a small proportion of patients leading to HCC. So the main thing is the star is marked on the metabolic cause because this is the rising etiology in most countries these days. And why is it important? Because there has been a multi-center study in India itself looking at the incidence of hepatocellular carcinoma and the reason behind it, or the pathophysiological factors in etiology. And they found that, interestingly, that in India now, NAFLD or non-alcoholic fatty liver disease has become the most common etiology, almost accounting for 36%, followed by hepatitis B and C, and harmful levels of alcohol, which means the first real causative factor is NASH. So coming to management of advanced and unresectable HCC, this is a big framework which we have from the BCLC, Barcelona Clinic of Liver Cancer, where we know very early stage, it is either resection, transplant, or local therapies like ablation. When it becomes intermediate stage, localized to one lobe, or background preserved good liver function, we can try something like TACE or TARE and then use a TKA or even immunotherapy. But we see most of them in advanced stage C or D, where almost 50 to 60%, where it is extensive bilobar disease and major portal vein invasion, where we are left with only systemic treatment. We'll be focusing on the immunotherapy and the TKIs. So we either start with the immunotherapy plus VEGF combination or dual immuno, and on progression we switch to the other therapies which we have not used in the first line and try to extract maximum benefit out of each one of these therapies. And evolution, as we see in 2007, we had sorafenib. After that, for almost a decade, we did not have real breakthrough. Still, we got lenvatinib, which was proven in many trials to be non-inferior but more tolerable, and we are seeing it as higher response rates. Then came ramucirumab in the second line and cabozantinib in 2019. And from last 4-5 years, we are seeing multiple drugs being approved, with dual immuno Tremelie Durva being the latest in 2022, and of course in 2020 with atezolizumab bevacizumab and nivo-ipi also being recommended. So these are the earliest trials of SHARP and REFLECT. SHARP was the first trial where sorafenib was compared with placebo, and we got a survival close to 11 months, which was the best we could extract, and which was really path breaking at that point. But sorafenib is a hard drug to take, and we barely attained the maximum dose, with hand-foot syndrome, diarrhea being very difficult. The REFLECT trial then showed a non-inferiority in terms of OS, but better tolerability, better PFS, and I think we have all moved on ever since to lenvatinib as being the first choice of drug. Then the real breakthrough came with immunotherapy and immune checkpoint inhibitor and anti-VEGF, because we saw in pathophysiology the two main are immune evasion and angiogenesis. So IMbrave 150 worked on this concept of trying to combine both the immune checkpoint inhibitor and bevacizumab versus sorafenib. It was mainly, the region was Asia, Japan, and rest of the world. Locally advanced, metastatic or unresectable, no prior systemic therapy, and they stratified based on the region, ECOG performance, and they also included patients with major macrovascular invasion or major portal vein invasion. In fact, it's the only study which also took those VP4, so the major portal vein invasion, and also stratified based on AFP level. And it was they were randomized 2:1 for atezolizumab bevacizumab versus sorafenib, and the key secondary endpoints being ORR and as per RESIST and HCC RESIST. What we did see was an early separation of curves at just 2 months, and the curves continue to separate. And what we interestingly we see with immunotherapy, like Dr. Sai Vivek did say, that we do see some exceptional responders, and those they contribute to the tail of the curve being plateauing, and you have a major duration of response in these patients. And for the first time, from 1 year survival, we are seeing almost 52% of the patients surviving at 1.5 up to 1.5 years, and progression-free survival almost 1/4 of them at 18 months still being on the first line of therapy. So this was really path-breaking. And interestingly, but however, almost 70% of these patients in this trial were of viral hepatitis B or C, and so possibly they represented a more immunogenic tumors and hence contributing to a better response. So the subgroup analysis, of course, when they did, even though the study was not powered for this, they did show that the benefit was towards the viral hepatitis induced HCC, and the non-viral HCC possibly may not benefit from atezolizumab bevacizumab combination. But the study was not powered for the same, and this subpopulation was small. So it is hard for us to conclude this, but anyway, this was an interesting statistic. Coming to the safety, we had the same safety signals as we would expect with bevacizumab, with hypertension, proteinuria, and of course the immunotherapy related side effects of sometimes skin rash, fatigue, ALT increase, proteinuria, and hypothyroidism. So with this, so the next trial, instead of combining anti-angiogenic with checkpoint inhibitor, they tried a dual checkpoint inhibitor, IO, and the rationale was to have a checkpoint inhibitor, one at the tumor site, which is anti-PD-1, PD-L1, and another checkpoint at the lymph node site, where the antigen presenting cells first stimulate the T cells and hence anti-CTLA. So they had a rationale of combining two different checkpoint inhibitors at two different sites with a different intention, and hence enhance synergistic anti-tumor activity. And so this is how the STRIDE was initially started, and then Himalaya trial, where the Durva plus tremelimumab, and the reasons they said was to increase anti-tumor activity by reversing T cell exhaustion and allowing T cell activation respectively. So the CTLA4 is a regulator of T cell activation at the lymph node following antigen presentation. So Tremely works at the lymph node level at the level of post-antigen presentation, and durvalumab works at the tumor and prevents exhaustion by blocking the PDL1. So this was the thing. So initially there was the dose determining study, and it was found that durvalumab, tremelimumab were tried in various doses, 1 mg per kg, 10 mg per kg, and many such doses. And the important question, the clinical question was, could a single priming dose of Tremely with durvalumab improve immune mediated clinical activity in HCC patients while really keeping the toxicity at check? So hence with this, the study 22 first was started with the phase 2 trial, where tremelimumab plus durvalumab in unresectable HCC was started with a single dose of Tremely and then the durvalumab maintenance, the STRIDE regimen. So the part 1 was safety, to see any new safety signal or tolerability with Tremely at 75 and then durvalumab. Then part 2, they included a bigger cohort with single agent durvalumab anti Tremely at 75 plus durvalumab. And then they also had a safety run-in of tremelimumab at 300 plus durvalumab. And in the part 3, again, the STRIDE regimen was finally born with the T300 plus durvalumab. And in the study 22 at the pre-planned interim analysis, they found inferiority of the T75, hence that arm was scrapped, and it was continued with the STRIDE and the durvalumab monotherapy arm. So STRIDE regimen showed the highest efficacy compared with durvalumab and tremelimumab as monotherapies, where they said T300, just tremelimumab at 300 mg single dose followed with durvalumab and then followed by durvalumab maintenance, had the highest median OS at 18.7 months compared to much lower OS with all the other regimens. So with this study 22 as the proof of study, we started off with the phase 3 randomized open label multi-center Himalaya study. So in the Himalaya study, the inclusion criteria was patient age 18, BCLC B or C, no prior systemic therapy, child PUA, they did take only child PUA, and they also did include major vascular invasion, almost 25% of the patients, but they did not include the VP4 or the major portal vein invasion patient. Etiology, they did take almost 40 to 45% of patients with NASH or non-alcoholic steatohepatitis, compared to only around 20% in the IM Brave 150. So the arm D was closed before because they found inferiority in Tremely of 75 mg. Patients were randomized to Tremely 300 and durvalumab versus durvalumab alone versus sorafenib, which was the standard of care. And this was the scheduling, where in arm A, durvalumab monotherapy 1,500 given every 4 weeks. In arm B, 75, this was closed. In arm C, 300 durvalumab and Tremely in the first dose, followed by single priming dose of Tremely to act at the lymph node for priming the T cells, and then durvalumab every 4th weekly. What we did see, the important to note in the baseline characteristics, non-viral or NASH related represented a major population of 41% of the people. And they did also include almost 25% with the major portal vein invasion, which we commonly see in our real life practice. Other characteristics like PDL1 positivity and AFP were also well balanced between all the arms. And subsequent second line therapies, when they did see, even in this, they saw that any therapy, almost 40% of them did, patients also in the T300 plus durvalumab did receive, which means even after they progressed, the patients were pretty well enough or in good shape to also take next second line therapy, which would be either targeted anti-angiogenic or maybe even reintroduction of immunotherapy. So what we did see here was, for the first time, then we saw at 36 months, we were seeing the probability of survival, almost 1/3 of patients still being alive and doing well at 36 months. And we did see the classical plateauing of the tail due to the immunotherapy effect. So this was median OS of 16.4 months, but in the people who did respond well, the duration of response was far greater and a prolonged response. And it found that people had a 22% lesser death risk compared to patients who received sorafenib. And when we did a subgroup analysis, forest plot, we found that almost all of them favored the durvalumab plus tremelimumab, except few small subgroups. And interestingly, the non-viral hepatitis, which did not do well with the atazobactam arm, also showed a good response in the durva plus tremelimumab. And whether major portal vein invasion or not, extrahepatic spread or not, irrespective of PD-L1 status, all favored durva plus tremelimumab. Overall response rate was almost 80% in the STRIDE regimen compared to just 20. CR, which we will hardly think of in HCC, we did see a CR of almost 3%, and 17% had a partial response and 40% stable disease. The duration of response also, if you see the 25th percentile being 8.54, but 75th percentile where we saw speak about exceptional responders, they are still not reached. And it was well tolerable compared to sorafenib. Any treatment related adverse event of 75%. But if you see grade 3 and 4 adverse event, it's pretty balanced between sorafenib and the tremelimumab arm. And any 3/4 immune related is almost 12.6%, which we see which could be handled. And any immunotherapy requiring high dose steroids was around 1/5 of the patients. So the most common adverse events which were seen was around rash, pruritus, diarrhea, and hypothyroidism. This rash and hypothyroidism and pruritus commonly which we do see with the checkpoint inhibitors, but we must keep in mind of the colitis and hepatitis which could happen, or even the hypophysitis rarely it could happen with addition of the CTLA4. Treatment related hepatic or hemorrhagic events was also pretty negligible with 1.8 and 0.5. So hence, due to this, it is come as a category 1 recommendation in NCCN guidelines, with atazobactam and tremelimumab being advocated as a category 1 recommendation. So the conclusions: HCC is one of the topmost common cancers affecting Indians. There's a shift from viral to non-viral etiology responsible for more HCC. Immunotherapy combinations have shown better anti-tumor activity than just TKIs. Atazobactam is the new standard of care, and so are the new double immunotherapy combinations like Tremeli Durva and maybe Nivo Ipli also. STRIDE seems to benefit across all subgroup irrespective of whether non-viral or viral etiology. And even in those group with severe portal hypertension, big esophageal varices where we are worried to use bevacizumab, maybe STRIDE was well tolerated even in them with low rates of gastrointestinal hemorrhage. So maybe STRIDE and durvalumab monotherapy represent a new potential treatment option for patients with unresectable HCC. So I think this as the research goes, we are getting more and more combinations, and it will be exciting for us to learn how to treat in the first line with so many options, whom we are going to give dual immuno, whom immuno plus bevacizumab, whom TKI alone, and where do we incorporate SBRT and TACE. So it will be interesting to learn. Thank you so much.
Thank you, sir. For the next talk, I would like to invite Dr. Abhilash, who is consultant medical oncologist at PHIO Mysore. Dr. Abhilash.
Are my slides visible?
No, sir.
I think you, Binu sir, need to stop sharing. I think otherwise.
I have stopped sharing, sir. Yes.
Yeah.
Sir, we will share the slide. Dr. Blush. Hello. Hello, Dr. Blush.
Hello.
I am sharing 1 minute.
Okay, sir.
Is it visible now?
Yes, sir. It is visible now.
Yeah. Sorry for the technical glitch. At the outset, I would like to thank Ravi sir for the opportunity and AstraZeneca. So we'll be discussing about real-world evidence with the durvalumab with gemcitabine cisplatin as the standard of care in advanced biliary tract cancer. So I'll be discussing about epidemiology, current management, immunotherapy in the first line, and TOPAZ trial outcomes. So I think we all know that gallbladder incidence is increasing, and this is the estimated projected cancer statistics in India in 2020. So, in according to this, about 1 in 422 male and 1 in 284 females, they usually diagnosed with gallbladder cancer. And this is the regional prevalence. I think is a retrospective study which was conducted at the Command Hospital in Lucknow. About 245 patients were diagnosed in the study period, and of it, more than two-thirds were women. And the major cases, almost 73%, were from UP, Uttar Pradesh, and the highest number coming from the eastern districts closer to the river Ganga and its tributaries. UP followed by Bihar, MP, and Jharkhand. So there has been increasing trend for in the incidence of biliary tract cancer in both males and females. So there should be high index of suspicion even in young patients who are presenting, and as we can see with the increasing age, I think the incidence is increasing, more commonly seen in females. So this is the 25 gallbladder cancer incidence data from the Cancer Registry of Delhi 2020. So we can see total incidence of cases right from 1988. They exactly like 5 year intervals. So there has been increasing trend in number of cases with biliary tract cancer. That is same with males and females, and the incidence is almost double in females when compared with males. So in the last 25 years, I think about 12,410 cases were registered and in India, and approximately constituted about 3% of male cancer and 6.5% of female cancer cases. And median age was about 60 years in males and 57 years in females. And there has been overall increasing trend. So coming to the current management, I think biliary tract cancers, whenever they present in early stage, we usually do surgery and followed by adjuvant capecitabine as a treatment. And the patients who are unfit, and we can take them as liver-elevated intrahepatic cholangiocarcinoma, radiofrequency ablation is the option. Whereas locally advanced, they advise molecular profiling followed by gemcitabine, cisplatin, and immunotherapy-based treatment. And post, if they're responding well, I think we can take them up for surgery. In case of advanced or metastatic cases, molecular profiling followed by cisplatin, gemcitabine, durva, or pembrolizumab. And once they progress, we usually take them for second line like Folfox, Irinotecan, and all those things. And once we have molecular profiling, I think we have a lot of actionable mutations where we can use targeted therapy like IDH1, FGFR2, BRAF, R2, RET, and BRCA1 and BRCA2. So NCCN also it recommends durvalumab with gemcitabine and carboplatin as a category 1 recommendation. along with pembrolizumab and gemcitabine cisplatin. So based on this, they are the preferred treatment regimens, including those patients who are MSI high or MMR deficient. So coming to the Topaz 1 study, it is a phase 3 randomized double-blind placebo-controlled multi-center global study for the first-line treatment in patients with advanced biliary tract cancer. So they included patients who were previously untreated, unresectable, locally advanced or metastatic biliary tract cancer at the initial diagnosis, or those who were recurred after 6 months after undergoing curative surgery or completion of adjuvant therapy with a good performance status. About 685 patients were enrolled, stratified according to disease status and primary tumor location. So patients were randomized to receive durvalumab 1500 mg every 3 weekly with gemcitabine and cisplatin for about 8 cycles, followed by durvalumab maintenance every 4 weekly until progression of the disease. And it was compared with placebo. And primary endpoint was overall survival, with secondary endpoints like PFS, overall response rate, duration of response, disease control rate, and quality of life parameters. So gemcitabine and cisplatin now is the only and the first approved IO combination because it has shown 2 years with durable overall survival benefit. Median overall survival is about 12.9 months versus 11.3 months, and the hazard ratios are getting better once they cross 6 months. Hazard ratio after 6 months is about 0.71, and there is even patients are responding after 2 years, like 24 months overall survival is about almost 2 times. It is 24.6 months versus 11.5%. So it also has demonstrated statistically significant superior progression plus survival against only when compared to chemotherapy alone, with a PFS benefit of 7.2 months versus 5.7 months, with a hazard ratio of 0.75, and 12 months PFS is 16%, and they continue to benefit after 12 months with a long tail. So coming to the response rate, I think the Durva arm has almost a overall response rate of 26.7% versus 18.7%, and about 2.51% patients had complete response, and 25% had partial response with a good disease control rate, and even the duration of response is about 6.4 months versus 6.2 months, and median time to response was good when we used immunotherapy with chemotherapy. So the patients, I think those who responded, like those who had either complete response or partial response, they did better even beyond 2 years. We can see about 91 patients that responded in durvalumab arm, and in those who were responded, the median overall survival is about almost 19.5 months versus 15.7 months, and the 2 year overall survival rate is almost doubled by 20.5% versus 40.6%, with a hazard ratio of 0.69 compared to those non-responders, those who had HR of about 0.77. So whose benefit was seen across subgroups, be it the recurrent disease or like newly diagnosed de novo metastatic disease or that primary tumor location. So all of them have favored durvalumab with chemotherapy. And addition of durvalumab to chemotherapy did not shown any significant new safety or toxicity after adding immunotherapy. I think both they did fairly well. Safety profile was similar in both the arms, and treatment related discontinuation, when you see, it is quite slightly higher in the chemotherapy than the placebo arm. So regular chemotherapy related side effects and very less likely immunity related side effects like grade 3 and grade 4. And discontinuation rate was actually more in the placebo arm, maybe about 15.2% versus 13%. So when they looked at the impact of mutation status on the efficacy outcomes, they have done an exploratory analysis. I think the most frequent genetic alterations were seen in P53, cyclin pathway, KRAS. They were the most frequently seen genomic alterations, whereas actionable alterations were seen most commonly in IDH1, R2, BRAF, and FGFR2 were observed. So even the patients who had genomic alterations also, when they have done a subgroup analysis, and there was similar overall survival benefit was seen with durvalumab, being P53 being the most common and KRAS being aggressive. So they have done well in the durvalumab arm. And some for some R2 and other things, the 95% confidence interval wide because of the low prevalence. So we have certain real world evidence. I think this one is from Italy, and again, about 145 patients were enrolled in this study, and most commonly they had intrahepatic cholangiocarcinoma, and only for 28% of the patients had a previous surgery, and other subgroup analysis, subgroup factors were equally matched. So again, in this real-world evidence, I think median PFS and median overall survival, they were similar to Topaz-1 trial, with a median overall survival of almost 13 months and median PFS of about 8.9 months, which are similar to Topaz-1 trial. And again, about 666 patients were evaluated, and including 11 countries and 39 sites. So most commonly, patients had 20% had gallbladder cancers, and 76% of the patients had metastatic biliary tract cancer. And they found out the median overall survival is about 15.1 months, and the response rates are up to 30% were seen in the real world evidence update. So again, the hazard ratios for overall survival and PFS were impressive with 0.59, and for overall survival, and for PFS with the hazard ratio of about 0.57. So adding durvalumab to chemotherapy definitely improve the overall response rates. So the objective response rates of reaching up to 35%, partial response being 30, almost 30% versus 5% complete response rates, and even the adverse effects are mostly likely due to chemotherapy components and less likely due to addition of durvalumab. So real world evidence, this data is from India. I think most of the participating like premier institutes like AG Hospital, TMH, Apollo Chennai, so almost 12 centers were involved in this data collection. About 148 patients were included in the study, and most like a patient had 63% patients had gallbladder cancer, then intrahepatic cholangiocarcinoma, then extrahepatic cholangiocarcinoma, and about almost 25% of the patients had ECOG performance status of 2 or more than 2, and most of them had de novo metastasis. So the thing is here they have involved almost 25% of the patients who had performance state of 2 or higher, and gallbladder malignancies were the most common. So about almost 64% of the patients had gallbladder cancer, and 85% of the patients had upfront metastasis. And as I said, PS2 was seen in 25% of the patients. So even Indian real world evidence, I think it is coping up with the Topaz-1 study results with a median PFS of about 8.2 months and median overall survival of about 12 months. So it is even considering the heterogeneity of different centers of India, so the trial results are consistent across the all the patient population. Again, safety profile is again similar to that observed in Topaz-1 trial, and in no major the grade 3 and grade 4 toxicities were seen. So conclusion, I think with the real world evidence experience, it appears that they're mirroring the survival rates and PFS rates with when compared with Topaz, and there were no new safety signals were there, and even those patients who had performance status of 2 or more than 2 also they were done by the addition of durvalumab. And even the gallbladder cancers were the most common. I think with the addition of durvalumab to standard chemotherapy, they have done well. So the Topaz 1 trial establishes durvalumab as the first line treatment for unresectable and metastatic biliary tract cancer. So there is no new toxicity concerns, and both it is shown to be safe across both treatment arms. And those patients who had clinically actionable and high prevalence genomic alterations like P53 and KRAS also they have done well. And also real world evidence from India, it confirms that addition now to durvalumab to standard chemotherapy, it has improved outcomes for biliary tract cancers. Thank you.
Hello. Thank you, sir. For the next talk, I would like to invite Dr. Ravi T.
Yeah, thank you. And let me share my screen. My screen is visible.
Yes, sir. Visible, sir.
Yeah, thank you. And I thank Zydus for giving this opportunity. So as we all know, in breast cancer, with the advent of HER2 inhibitors, the prognosis have improved. And pertuzumab is one molecule where we are using for many years in early locally advanced and metastatic breast cancer. We'll see how the things have changed with the generics. If we see the HER2 targeted agents from starting, I think trastuzumab, after the trastuzumab usage, I think the next generation of HER2 inhibitors like pertuzumab, then Ujvira, then Enhertu, and now orals like tucatinib. So there are a lot of molecules which are available and which is good for clinicians and patients because we have got multiple options now which we can use it. Coming to pertuzumab, as I discussed, we use pertuzumab in neoadjuvant, adjuvant, and metastatic setting. Hello, hello, क्या हो रहा है? वीडियो शो नहीं हो रहा है? ओके. Yeah. Now it is clear.
No, sir. Sir, please remove your background screen.
How to do it? So view profile. How to remove the background screen?
Technical team. Hello, technical team. Sir, sir, you continue the talk.
Yeah. So pertuzumab has been used in various scenarios, as I discussed, in neoadjuvant, adjuvant, and metastatic setting. If we see the major trials, landmark trials of neoadjuvant, Neosphere and Trifina, the Neosphere, where neoadjuvant trastuzumab, pertuzumab plus chemotherapy, which showed increased pathological CR rates. and Trifina also showed increased pathological CR rates. But are all pathological CR same? Definitely no, because it has been clearly shown that when we achieve pathological CR when we achieve pathological CR from dual HER2, they are much superior as compared to the single HER2. So the
Hello.
high risk pathological CR should be. Hello.
Ravi sir, please rotate your phone screen.
Yes. Please, sir. What I should do? This is the PC.
सर वहाँ पे एक ऑप्शन है, आप देखिए वीडियो के बाजू में एक छोटा सा अपर एरो होगा, वहाँ पे क्लिक कीजिए।
वीडियो 1 सेकंड
सर आपका वीडियो जो है वो उल्टा फॉर्मेट में आ रहा है।
ओके, वीडियो का क्या चूज करना है? वीडियो सेटिंग्स में।
यस, आप वीडियो सेटिंग्स में क्लिक कीजिए एक बार।
ओके,
और देखिए अभी आपको छोटा सा विंडो पॉपअप हुआ होगा, वहाँ पे देखो आपको खुद का व्यू दिखाई दे रहा होगा, आपका ही व्यू आपको दिख रहा होगा। वन मोर, यस,
now it is
अभी
okay.
क्लियर है सर, प्लीज कंटिन्यू।
Okay, yeah, thanks. So are all pathological CR same? Definitely no, because we know that when the pathological CR is with the dual HER2, that is pertuzumab, trastuzumab, it is much superior as compared to the single HER2 inhibitors. And the test when the treatment included pertuzumab, trastuzumab in the neoadjuvant and adjuvant setting. That adjuvant pertuzumab, trastuzumab plus chemotherapy in early breast cancer operable, the survival, that is the median survival itself, is significant. So nowadays what we are doing is, if clinically, if we feel that the patient is early breast cancer but having nodes either radiologically or confirmed, even if they achieve pathological CR, we should not stop pertuzumab. You continue pertuzumab, trastuzumab in the adjuvant setting also, which is very important. So it has been clearly shown in the affinity updated trial also that the final OS is 11.3 years when we add pertuzumab to the adjuvant setting. And we can clearly see here, especially as I discussed in the node positive patients, giving adjuvant pertuzumab is very important. So even in the updated analysis at 11.3 years, we can clearly show that if the patient is having node positive, irrespective of the receptor status, that patient will benefit with the adjuvant pertuzumab. And the latest NCCN guidelines also clearly shows that those patients who are having clinically node positive, even if they achieve pathological CR, so always continue pertuzumab in the adjuvant setting along with the trastuzumab, irrespective of the receptor status. Earlier, there was a notion that if the receptor status is positive, we may omit pertuzumab, but that is not the case. It's mainly the decision is taken based on the clinical node positive. So if the patient is having node positive, always give adjuvant pertuzumab. And sometimes what happens, the patient underwent upfront surgery in some scenarios. Even in that case, if the nodes are positive, always add adjuvant pertuzumab so that the longevity will be better. One more recent study which shows that Cleopatra, the analysis again shows that the OS is much superior when we add dual HER2. And carboplatin is plus or minus. Nowadays, I think with the recent evidence, so we are not giving carboplatin in many of the patients. And we can clearly see here the OS improvement. So in the metastatic breast cancer, dual HER2 plus docetaxel is the standard of care. So similarly, even in the Patina study, which shows that dual HER2 is the standard of care, and nowadays with the Patina, even that HER2 and endocrine also, there are a lot of evidence showing that pertuzumab given to the trastuzumab has got better benefit. Again, her claim study where since the tucatinib we are using in our practice, it clearly shows that tucatinib is one more HER2 inhibitor where instead of earlier what regimen we used to use, that is lapatinib and capecitabine, this is much superior. So of late, if we see the HERCLAIM trial, especially if the pair switch to the HERCLAIM protocol, the tucatinib initially we had a little bit skeptical how our patients tolerated, but with practice it's clearly shown that our patients do tolerate well, and dual HER2 plus tucatinib is definitely superior, and we have seen good intracranial responses also. So adding tucatinib with to trastuzumab and pertuzumab in first-line maintenance therapy definitely will improve PFS and also the intracranial PFS. So clearly, if you want the CNS PFS benefit, tucatinib when we add to dual HER2, it is much superior as compared to giving only dual HER2 inhibitors. So with this, I will conclude. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Satish CT for the panel discussion, redefining treatment option of
Right
TEN-centric
at
for
the
the
beginning,
patient
at least
with
in
advanced
cholangiocyte,
NPLC.
there are 2-3 issues to consider. The first thing is that the PFS too. So the dropout rate between first line and second line is significant. So not enough of our patients might actually end up living to see the benefit of a second line targeted therapy pickup. So that is one thing we have to consider. The second thing is that things like FGFR2, at least although they are rare, if they are there, it is a significant driver mutation, and there is indication to use those treatments. So definitely, I would prefer to do it upfront. And these mutations are usually stable mutations; they don't change. So it's not like we do it in first line, we do it in second line, we'll get a hugely different report. Sir.
Absolutely. They are disease defining mutations, so they are truncal mutations basically. They are picked up to be.
Hello.
Sir, yeah, you're audible.
Shall I start from my, yeah. Hello.
Yes, sir. Yes,
Ravi,
sir.
Yes, sir,
is
you
it
are
come
audible.
audible? Can I start my moderation or not? That's what I have to wait for
Yes,
someone.
sir.
That's
Yes,
what.
sir. Yeah, please start.
Yes, sir, you can.
Okay, that yeah. Thanks, Dr. Ravi, for giving the opportunity to moderate this session. Just 1 minute. Like my slides are visible, no?
Sir,
Yeah, visible.
sir, make it
Okay, Dr.
full.
Lokesh, no, yeah. Dr. Lokesh, Dr. Smita is there, and that other one just
Satish, I'm there.
panel. Yeah. The 3 panelists, no, like here actually.
Sir, Dr. Hemant,
Hemant is Dr. Hemant
Dr.
Suprit,
R.N.
Aditya.
Suprit and Dr. Aditya Mulli.
Okay, fine. Sure, okay, just like I'll try to discuss like the what this today I'm going to talk on the like we are going to discuss about the how we manage the platinum ineligible lung cancer patient. What we have this is one of the really challenging scenario in our day-to-day practice. This is my disclaimer. Just like we heard from like various speaker and breast cancer and other cancer, let's just we are starting lung cancer session. Like that lung cancer is one of the significant global health issue. You can see that almost like 2.4 million new cases, like 1.8 deaths, like that's globally. But Indian perspective, it is almost 81,000 new cases we can see. It is one of the most common cause of cancer, like death in globally, also in India. That's what we try to see. And if you coming to the that scenario like this the management of any lung cancer patient, there is various factors. There are three factors we can say that is specific to the what is the type of lung cancer. That's histology and what is the molecular biomarkers and sometimes we don't have a like, no biomarker and we have some identifying the that immunotherapy biomarker PD-L1 and okay and okay, and the disease factor, like patient factor, will see that other factor, like this, the disease factor, like based on the stage of the disease and what is the site of burden of the disease, can be a liver mets, brain mets is there, and like a symptomatic fitness is not there, and comorbidity and performance status and age. These are factors will come. And next other things that even though this patient and like a disease factor is there, and various other factor in the patient wish and family which is there, and even the treating physician also they are having preference of what kind of that regimen they want to practice, and social factors and also financial factors will come, and even availability of clinical trial in that stage. These are factors will come. If you come to the management of the first line cancer without lung, like I'm not going to go for the driver mutation, without actionable mutations are there, you can see here the first line management, how it is evolved. Actually, we used to just bombard with the only chemotherapy, different fermentation combination. We used to do that. We used to have some survival benefit, but we can see that a lot of evolved in the treatment, the management of the lung cancer. The first line chemotherapy, the chemo with anti-angiogenic drug, chemo immunotherapies are there, like monotherapy, with immune checkpoint is there. Triplet therapy is also there, like you can see in the form of quadruplet therapy. That's what the two agent of chemo with the bevacizumab and the immunotherapy is also is there. ABC regimen, and also like doublet immunotherapy with chemotherapy. There are various combinations are there, like and even after progression also you can see that you can have a chemotherapy alone. If an anti-angiogenic drug is not used in a first line, you can use anti-angiogenic drug with chemo, immunotherapy, monotherapy. Like these are the options are there. These are the challenges. Like this is that we are able to okay that data is there. They're all clean patient, fit patient, we try to do it. But when you're coming to our day-to-day practice, we'll see the patient, okay, platinum eligible. It is one of the definition also is not uniform in across all the trials. It is the variability is there, and the real world the studies also variation of that definition cutoffs also heterogeneity definitely complicates the interpretation of outcomes. And then how and what you define the that like factors to see that platinum eligibility. These are the factors will come. Dr. Smita, that if you come this age factor, what is the age you are going to consider the elderly person, okay, age person? What is any specific cutoff, Dr. Smita?
So usually when we see the age above 65 years, we will take it as elderly. I mean, 65 years is not elderly per se. If it's a fit patient, we will take it as, okay, we can go ahead. But above 70 years, usually we'll put it as definitely elderly. And ineligibility to platinum doublet usually will be above 70, 75 years. Usually we are a little skeptical to use platinum agent. Less than 70, comfortably we use carboplatin. It may not be cisplatin. Until the age of 65 years, I comfortably use cisplatin.
Okay. Any other one like a Supreet? Anyone you want to add actually? That Lokesh or anything? You have done some different perspective in the age concern.
Yeah,
Supreet?
age usually the different guidelines say different age cutoff. What usually they say is more than 65, some guidelines. But for usually when it comes to platinum, for cisplatin, usually I keep a cutoff of around 70 years of age. Carboplatin up to 80, I feel okay with some dose modification to manage.
Hello, sir.
Yeah.
Lokesh? Yeah.
Sorry, sir. Good evening, all. So I was listening to the question. So as Lokesh sir and Smita madam were suggesting, the widely accepted cutoff to define elderly is 65 years. But in gen practice, I see frailty as such. I even do frailty scores like G8 CARG scoring to see what are the chances of that patient ending up having toxicities. Specifically pertaining to cisplatin, I don't follow any age cutoff. If the patient's renal reserve is fine, no cardiac comorbidities, no neuropathy, I'm to use cisplatin. So my definition would be mainly based on a holistic approach towards frailty as such, rather than just the number.
Okay, okay. I think like that is a performance status is very the important point, and also age is as a factor. That is a yeah that the different guidelines they have a different definition. Like India, we may see that 60 years. Some people even we go up to 70 years also. Based on that, the performance status is the one thing. If it's good, we may stretch about not only 60, you may extend, but still it's not easy to like above 60 years that the various the comorbidity organ dysfunctions will be there. That is a challenge when we are treating our Indian patient also with they are different like a Western patient fit patient they are on different guidelines of 65 70, and when they're coming for individual platinum in the form of cisplatin cargo there are different guidelines there. But ultimately the whenever we, with the age with the reduced organ function definitely is like they are all susceptible to for toxic side effect of the chemotherapy. That's why we have to be very very careful when you're dealing with these kind of patients. And yeah, the frailty score assessment and the fitness is more important. And coming to the next other factors about the performance status of the patient, how do you, Smita, that how do you feel like that the influence your performance status? I think yes, more of little bit twisting about the old question only. Age and like ECA performance status slightly they're all they're dependable, but it might vary also.
I think until performance status 2, I'm comfortable using platinum. So maybe I will switch to using a carboplatin instead of cisplatin. But I think above performance status 3 and 4 definitely will not use platinum.
Okay.
Performance status 0, 1, definitely cisplatin. I think 2, usually I tend to go to carboplatin.
Okay, anyone say that opposing this one? Performance status. Some people performance status 2 also I don't treat. Some people they say that some clinician, and some people I know I'll do it like this. What okay? The some people they have different version of split dose. So many things they'll do it. But many people they're adopted. I think carboplatin in the place of cisplatin in the exceptions. So, and Smita, do you feel like cisplatin mandatory some your regimen or all the time you interchange with the carboplatin?
So whenever cisplatin, I think it's very important, specifically in small cell lung cancer. But most of the time, I think for non-small cell lung cancer protocols, carboplatin is comfortable. You don't have to use cisplatin. So I'm
Okay.
comfortable using carboplatin.
Where do you prefer cisplatin? Like which patient we try to prefer a
So
cisplatin?
in lung cancer per se, small cell lung cancer, and I think the germ cell tumors, head and
No, no,
neck. In non-small cell.
lung cancer
Non-small cell, I
practice.
think,
Which area we want to practice in each part of the type of lung cancer? Where do you prefer a cisplatin?
I think wherever patient is fit and you're using probably uh, the induction regimen or in the neoadjuvant setup, usually would prefer using a cisplatin
Okay,
neoadjuvant.
okay. Hemant, Dr. Hemant, do you have anything opinion
Yes, sir.
from? Yeah.
No, I do agree with madam. So until PS2, we are comfortable using platin. Sometimes I end up using a weekly paclitaxel carboplatin regimen in case I'm not able to give a 3-weekly regimen in case of if the general condition is not that good. Cisplatin mainly in adjuvant setting is where I definitely would not switch to carboplatin. That is one setting definitely I would consider cisplatin and try to do that. But most of the places in metastatic setting, I end up using carboplatin instead of cisplatin.
Hemant?
Yes, sir.
Hemant, hello. Yeah.
Hello, sir. You can hear me now?
Most likely you try to use a carboplatin. Yeah.
Yes.
Yeah, I can
So
hear it.
in
Was
all
like just
in all metastatic
slight disturbance
setting
was
is
there, but
usually
I think most likely you try to
in metastatic setting it is usually carboplatin. In curative intent, there I would definitely prefer to use cisplatin. Weekly paclitaxel carboplatin is something that I've used in case the general condition PSS 2 or so. Only when it's 3 or 4, the question comes, should I really treat or not?
Okay, okay. Okay, I think anyone is have some difference of opinion other than like Smita and Hemant, Lokesh.
Always
Okay, I think
carboplatin
most likely
only in
will like
adjuvant it
because
is
some
cisplatin.
germ cell tumor, yeah, we want us.
Always
Yeah, like
carboplatin unless in adjuvant it is cisplatin.
yeah, like see that that's we individual practice may be different. A clinician, okay, the patient is performance status is good, even the age people, but still that GFR, all the things that even the elderly people we cannot practice cisplatin. Many of us we are I think interchange with the carboplatin, but exception some cancer like definitely carboplatin like we may not replace easily like when they are using the cisplatin the golden the rule that we'll try to use most of the cisplatin. But lung cancer, majority we practice like a carboplatin in place of a cisplatin, exception some patient. Say I try to practice like fit patient, like young, like when you are using a femitrexate based combination, I to cisplatin fit patient, definitely I'll prefer a cisplatin rather than I don't interchange with the carboplatin frequently unless is not fit for eligible to take a cisplatin. They're only elderly people that try to take. Otherwise, majority with the taxanes and other like we try to interchange easily with the carboplatin, we'll try to do it. But when CTRT that like the are like a adjuvant treatment recommendation they try to use a cisplatin. Many of that we try to interchange with the carboplatin. And here performance status is very important. Like that's what like poor performance status they definitely that imply the chemotherapy side effect, myelosuppression, a lot of tolerance is not easy. When you're using like performance status is up to 1, definitely we go for a doublet in the cisplatin. And like if you go for a performance status goes down, many people they may see palliative treatment or maybe weekly schedule or single agent treatment. Various permutation combinations we try to do. Sometimes we may use it like metronomic therapy. So many things we try to do it, but we'll try to see that whether patient is fit for this, eligible to go for platinum eligibility or there or not, borderline performance status. We'll try to see various factors. We try to see that. Next factor is the one of the thing renal function. How do you see that renal function will be deciding the eligibility of a platinum doublet plus or minus immunotherapy? Dr. Smita?
So here usually I do the JFR scan. So usually we go with the calculated Cockcroft Gold formula. Look at the creatinine and look at the GFR, calculated GFR. If it's an elderly patient above 65 years, I usually tend to ask them for a GFR scan and then look at it. If the GFR value is less than 70 ml, definitely not a right person for going for cisplatin. And there, usually, I think we will avoid platinums.
Okay. Anyone having a like a do you practice GFR scan like for everyone or like only selected cases? Dr. Lokesh?
Yeah, usually we don't do GFR scan. So we just look at the patient with comorbidities, with elevated creatinine. Maybe I think of doing GFR to decide whether at least I can give carboplatin. So usually I don't do unless there are comorbidities or pre-existing diseases that will alter.
Okay. I think there are like
I actually agree with Dr. Lokesh in the sense that, I don't remember last time we did a GFR scan, at least in a metastatic disease. Yes, if it's a adjuvant disease, adjuvant treatment, patient is very fit, maybe we would want to give cisplatin. But when we're giving carboplatin, Cockcroft is fairly okay, unless, creatinine is high and we are desperate, we still want to give some kind of carboplatin, maybe then we will do. But metastatic disease, I don't remember last time we did a scan.
Okay, okay. Thank you, Aditya, regarding the adding up the points. Like, really, that is important is see that like GFR scan, many of us we don't do routinely. Like that's what sometimes exception like cisplatin curative treatment whenever you want to use this. Not only lung cancer, some other cancer also curative treatment. Then only we may practice. Many of us like easily because our practice is morely carboplatin based. We try to practice with the like calculation from the that. body weight and serum creatinine, like calculation, we'll try to do it and we'll practice. And next question to Aditya, like see carboplatin, see that there are the various the trials, they have a carboplatin less than this one, less than 45. I don't use it. What is your practice? The many trials they gone up to even 40, even 30 also. If the creatinine clearance comes to 30 to 40 or 30 to 45, what you do? You do you practice with a doublet platinum with a plus or minus immunotherapy, or how do you practice? I know cisplatin you don't give it.
Hemant here.
Aditya?
Yeah.
Hemant, you
Can I
can
come
take
in,
up
sir?
this.
Yes, sir.
Yeah.
Yeah. Cisplatin becomes an issue when the creatinine clearance drops. But carboplatin is something I still end up using to whatever extent is feasible, because based on creatinine clearance, I've not really seen. The issue comes when we end up using pemetrexed and carboplatin. So if the creatinine clearance is less than 45, then the problems we end up, if we kind of really start this patient less than 45, we'll probably definitely avoid or reduce the dose of pemetrexed. The problem comes in case the creatine starts rising, you're really not sure what is happening there. So that situation, I end up using taxane along with carboplatin to ensure that I'm not in such a situation. But otherwise, I still end up trying to use carboplatin based on the calculated cognitive formula.
Yes,
Actually, to add to what Hemant said over there, there are occasions wherein we have given this for even patients with renal failure. At which point of time, obviously, we try and time it along with the dialysis, and we try and take GFR as 0 and give carboplatin 50 mg at that time, 25 mg, something that we give at that time. But essentially, if it's less than 45 ml, it is really tricky. And if we have got other options, we should try and explore other options.
Okay, thank you, Aditya. Thanks, Hemant. Regarding, see, like, yeah, cisplatin, some protocol for even 50, 60 also, less than majority is less than 50, we don't practice. Now that the 50 to 60 borderline is there, even we can, many people, they try to use split dose. Like now, like in various cancer, they have a day 1, day 2, that split dose they try to practice. But carboplatin, less than 45, like we may not practice. Some people definitely even up to even 30, also 35, up to 30 we try to use the carboplatin if we have some regimens like an taxanes with the carbo. But if we are going for pemetrexate, is a contraindicated. Less than EGFR is less than 50, you should not use it. But if you, even if you do, you definitely, Hemant is clearly made out, you have to do the dose modification. If the GFR, like EGFR comes less than 50, don't think that only platinum, even pemetrexate also, that there is content in the clinical trial, there will be exclusion criteria. Less than 50 is their EGFR, you should not use a pemetrexate. These are criteria are there. You should be very careful when you're using that is one of the challenge, like, because many of our patients, 30 to 40% of patients, they may come to this criteria. This renal factor is one of the important thing. We have to be careful in EGFR also. We may stretch out and we try to do it, but many patients falls in this the group actually less than 45 or even 30 also. Next factor is coming the comorbidity. How do you, like, to the what extent you see like a comorbidity also can influence your decision, like withholding platinum based treatment, like because you have found that in the performance status, age, and renal function, Smita?
So I think performance status, if patient's performance status is more than 2, then and patient is uncontrolled diabetic, having any cardiac issue, hypertensive. So usually cardiac issue with the reduced ejection fraction, these patients or patient with the elevated creatinine, as we already discussed, these patients definitely I'll try to avoid the platinum.
Okay. Lokesh?
Yeah, mainly for cisplatin, if the patient is having some pre-existing cardiac disease with declined cardiac function or ejection fraction and or in cardiac failure, I try to avoid cisplatin. So mainly that is the only one. Otherwise, usually diabetes, hypertension, I may try to do GFR if it is really increased creatinine to find out the exact creatinine clearance. Otherwise, I don't think such the diabetes or hypertension will alter my plan of using platinum.
Yes, definitely. That points are well made out. See that comorbidity, we have multiple things like see diabetes, hypertension, like the extreme version of this like comorbid. Definitely, we cannot use this platinum doublet based treatment. if you use that, definitely you lead into a lot of adverse event, SAEs, and definitely sometimes we lose a patient also. We have to be very careful. And also there are factors are there, like altered liver function, chronic liver disease, like those are the things are like very careful when you're using. Not only the cardiac thing, like the hypertension, definitely we can control and do it. If it's uncontrolled hypertensions are there, some of when you're using TKs, other thing. But anyway, this platinum, like we have to be careful. Renal damage, all the things like will be there, and autoimmune disease there, uncontrolled psychiatric problem. There uncontrolled any comorbidities there, definitely we cannot use tablet based chemotherapy. It's very difficult to manage the adverse event of following the chemotherapy side effects. These are the factors I think we have seen that we heard from everyone, like a performance status, age, and renal function dysfunction, and also like a comorbidity. These are the factors they try to influence, but there are like maybe one factor maybe influencing other factors also, like because the comorbidity they'll have a performance status will go down, because aging also PFS goes down, and even associated with the comorbidity renal dysfunction. They're all interlinked, and we have to be very careful. Not one factor, multiple factor can influence. You see this, like these are the four factor we try to see that they're all interlinked. And in your if you have that estimation, what percentage of the patient you see the clinical practice fall in the platinum ineligible category in Dr. Lokesh?
Yeah, platinum, if we take cisplatin around 40%, if we take carboplatin, maybe around 20%.
Smita?
I think cisplatin ineligible around 30 to 35%,
Okay.
and others are eligible.
All patients are eligible.
No,
Carboplatin.
30 to 35% ineligible.
Okay. Okay, cisplatin like I had. Okay. Cisplatin is slightly more, and carboplatin is still borderline. We can use it. That's what I think we heard from
Carboplatin, I
Lokesh.
think we are
Yes.
relatively safer, comfortable using it
Yes.
because we give a low doses.
Yes. Anyone like the Supreet? Do you have anything like what is your practice, Supreet?
Sir, cisplatin, as everybody were suggesting, almost I feel around 20-25% of the patients would be ineligible. But carboplatin, I don't think we should have much trouble, sir.
Okay.
At least when it comes to using it along with weekly paclitaxel carboplatin, if the patient's performance status is poor or is too frail, we try to push at least weekly paclicarbo.
Yes, we'll do the modification borderline patient. That's what we'll try to do. But cisplatin eligible, we come across. That's what I think. In your institution, I think you try to see more fit patient than I think other people. I think more or less there are around 35 to 40% of people may not be eligible for cisplatin. Various factor, not only that lung cancer patient. I'm not telling about other general cancer. Lung patient, I'm telling you about the various factor. We may not able to give a cisplatin based treatment. And if you go for the statistics like ineligibility, because if you go for the almost real world evidence, they say that more than 40% of patients without lung cancer, they have a performance status more than 2. Substantial comorbidity will be there, and they'll be out of clinical trial. Maybe not only immunotherapy based trial, and even other even chemotherapy based trials also. If the performance status is equivalent or more than 2, they have proven that the survival will be very less, and definitely they'll be out of the trials. And even age factor, so some of the trials they try to see that above 70 years they won't take it. The only immunotherapy single agent they can intake up to even 80 years also. But many chemotherapy based trials they may not take more than 70 years. In India, common age like age almost like 63 years. They may trials, Indian sponsored trials, they may go up to 65. But real world evidence, we try to see this is statistics. But looking at all the things, comorbidity, contraindication to all the things, we try to up to 35 to 40% patient may not be eligible for the cisplatin. Carboplatin may go down to around 25%. That's what we try to do. A lot of modification. This is the unmet need in this population. What we try to see that, because we don't have the limited evidence of systemic treatment, because they don't be included in the clinical trial. They may go single agent treatment or supportive care, or that are underrepresented in clinical trial because of the old frail patient performance status. They're not like represented any clinical trials unless there's someone especially done a clinical trial in this kind of patients. And safety tolerability, that's why they definitely influence the outcome. That's why they don't be included in the clinical trial. And worst clinical outcome, we try to see tolerability of the concern, and the many sponsor, there'll be there the drug, and they try to have the bad influence on this the drug. That's why there many people they don't include the clinical trial in this kind of patients. This is the challenge that given this challenge with this subgroup, what is your preferred treatment like platinum eligible patient? Like see these situations are what how do you manage, Dr. Aditya? Lokesh?
Yeah, platinum ineligible, it's very difficult to manage. Of course, most of our patients will not be eligible for immunotherapy, as single agent immunotherapy is an option. So I always end up using a single agent paclitaxel or gemcitabine. If patient is really affordable, I'll go for a single agent immunotherapy.
Do you have data for that immunotherapy? Which
Single agent,
immunotherapy you prefer? Means
I
like
think
do you see
we have some data,
subset?
of course.
Means some set like subset means like Fidelin more than 50% you'll
Yeah,
use it,
we
or
have
it is
more
not?
than 50. Of course, we have good data for pembrolizumab using single
Okay.
agent, especially when the disease burden is not high. We can
Okay.
clearly use pembrolizumab. So I
Okay.
think now we
Okay.
have atezolizumab also data is there. So
Yes.
that is also
Yes.
an option for our patients.
Yes, yes, that's what like that we are coming for that. But like the other challenge about the PDL1 is less than like 50% are sometimes not there. What we are going to, this is one of the common challenge for us. Many of us we may use a single agent gemcitabine, vinorelbine. I think vinorelbine no one is practices actually. Docetaxel I think is very toxic regimen. We may use a taxanes weekly, nab-paclitaxel. We may use single agent pemetrexed. So there are data are there like phase 2 phase 3 data, but you can see look at the median and survival rate with the single agent chemotherapy drugs. You can see none of them crossed more than 7 8 9 That's what you can see. Docetaxel 5 months and pemetrexed for 4.7 months. Gemcitabine has gone 9.8 months. This is the median survival rate we are trying to see that. How to see that immunotherapy is fitting in the landscape of our platinum eligible patient? Like Dr. Smita, do you want to add a comment on this? Okay, see that single agent immunotherapy in a frail patient, they have the data is very scarce. Actually, you can see no any phase 3 randomized in like a trial in the first like phase 3 data with the pembro data in a 4% status are of all platinum ineligible patient. We have a phase 2 data with the pembro. We can see the single arm phase 2 data in regardless of the fidelity status. You can see here 60 patients were enrolled and 24 patient in the first line and OS benefit of 7.9 months in the first line, median PFS of 4.3 months. This is that's what they try to see in the first line patient with the pembro data. And you see that Nivo ipilimumab, you can see double immunotherapy should do good. Actually, it was started in the phase 3 data, but it was because of the independent data monitoring committee, they stopped recruiting because survival is very detrimental actually with elderly patient more than 70 years. And durvalumab data also just like with the PDL1 more than 25%, they started resulting a high fatal, unexpected fatal event. That's why that is also stopped. We don't have any encouraging data with this actually. That's we have this interesting study data, phase 3 data. IPSA study, you can see this is the phase 3 first line atezolizumab that when compared to the single agent chemotherapy in the non-small cell lung cancer, which are not eligible for a platinum based chemotherapy. You can see here there's a because this I think already I told you that background we don't have good data with the immunotherapy with or without chemotherapy in the platinum and doublet ineligible patients. And real world data definitely more than 40% patients they won't be included in this trial for performance status and multiple comorbidity, elderly patient, all the things. With this like challenge, definitely we don't have good supporting data, and we don't have a good treatment regimen in this kind of we are supportive care. Sometimes we try to use single agent, weekly schedule, metronomic therapy, or sometimes palliative radiation. So many things we try to do it, but we have this data with this phase 3. You can see here is the treatment name stage 3B, like a stage 4 patient and squamous or non-squamous patient with a performance status of 2 or 3, and even performance status of 0 to 1 with age more than 70 years and even more than 80 years also included here. You can see EGF or ALK will be excluded here, asymptomatic brain mets. These are the things we try to see stratification. And here you can see 2:1 arm, like atezolizumab single agent, or like a treatment of physician of choice. You can see here single agent mineraloprolol or gemcitabine was used here till the disease progression. They tried to use the primary endpoint was OS, second endpoint of OS at various intervals 6, 12, 18, 24 months, PFS and objective response, and of course that is safety and patient related outcome. You can see this is the demography of the study here, the single agent atezolizumab versus the chemotherapy. They're all well matched. I'm not going in depth actually because lack of time. Smoking history, brain mets, and you can see the PDL1. That's most important for us actually. And you can see that less than 1%. You can see that like negative case almost nearing 40 to 50% of patients are there. Unknown patients also is there here, and like more than 50% is hardly, we can see 17% of patient here. That's what we can see here. We are hardly the more than 50% are very included here. You can see this is the ineligibility pattern of patient pattern because of this performance status 3 or 2 with the comorbidity, or good performance status with the multiple other things, like age factor also with the comorbidity. This is the factors can representation of the study. Do feel this representation in a platinum ineligible patient, this does it belong to your clinical practice, Dr. Smita, uh, Dr. like
Yes,
Aditya?
I totally agree on this because there are two really relevant things in this study. Is one is age more than 80, and second is ECOG PS3. Another thing relevant to our patients is that most of our patients at this age will also have comorbidities of heart disease, which actually preclude. So many of them come with low ejection fractions who might not be able to tolerate any kind of chemotherapy. So this probably really fits into that kind of category, and we do have 15-20% of the patients who will probably be not eligible for any other therapy but for this study.
Okay. Mm, I think this is a very interesting thing. OS definitely you can see here, like with this data, I can see that the primary endpoint OS is, you can see that median OS is 10.3 versus the 9.2 months. Hazard ratio is 0.78, and you can see that at the end of like 1 year, you can see the marginal difference. At the end of 2 years, you can see here, this almost near more than doubling that your survival benefit. Can see here 24%, like one fourth of the patients, you can definitely you can make them survive more than 2 years. That is very impressive data with this single agent atezolizumab. By seeing this 2 year OS data, does it your approach will changes in a platinum ineligible patient? Month?
Yes, sir. I think this is one area where we do not have option, and probably this will definitely add value to this. So definitely impressive data for a subset which otherwise we will not be able to treat at all.
Okay. Looking at the PFS data, also you can see here PFS is initially any immunotherapy don't see that any increment. You can see that treatment. You can see that started the improvement treatment towards the immunotherapy. At the end of 1 year, at the end of 2 years, you can see that definitely improvement towards the immunotherapy. Hazard ratio is 0.87. You can see here even response rate also. We can see that like a chemo doesn't show that shrinkage of tumor. You can see here that like a monotherapy chemotherapy, that we don't see that with this atezolizumab. We can see that near doubling the response compared to the chemotherapy, and that's very impressive data that with this. And you, because symptomatic patient also will be scared about, okay, immunotherapy doesn't shrink the tumor, we may have some stable disease, we may have some survival benefit. That's what we think, that it is like, yeah, I can see that this data is showing impressive that I can use the immunotherapy in this setting also, try to shrink the tumor. By choosing this platinum eligible patient, how much like does the quality of life is going to matter in your patients, Dr. Supreet?
Yeah, sir, it matters a lot because particularly in this trial, we are talking about the patients who are mostly elderly. We barely see trials like these coming out which are focused on geriatric population, because most of the pharma companies want to avoid patients with significant comorbidities who have shorter life expectancy. That is the natural tendency, but this is one good trial that is specifically focused in this area. And in these guys, it is important that we maintain quality of life more importantly than improving the survival. Survival probably can just be a byproduct, but quality of life is something that I strongly believe in, and this trial addresses that.
Yes, yes, like definitely, I think Suprati, you have made a clear cut point. Not only like, see, we'll try to see only renal function, platinum ineligibility, the cardiac function. These are two things we'll see. That neuropathy, that like performance status, like these various factors are there. That even neuropathy background of the, we definitely we cannot use the platinum drugs. And even carboplatin also background of grade 2 neuropathy, we cannot use it. We have to be very careful. You can see here that with the atezolizumab definitely is shown an improvement in the quality of life when compared to chemotherapy. You can see that various like see that at the even timing also with exposed to the immunotherapy, you can see the improvement in the quality of life towards the fatigue, dyspnea, chest pain, cough, all the things all favor towards the immunotherapy arm. You can see that adverse event. We know that immunotherapy we are using various cancer and we are using more from the almost many years, and we know that immunotherapy related side effects are very characteristic. That is about the some few side effects characteristic about the immunotherapy side effects. There are less when compared to the immunotherapy. Like, when compared to chemotherapy, immunotherapy related toxicities are less. There are some endocrine therapy related endocrine dysfunction, skin toxicity, or some GI disturbance. They're all manageable thing compared to the chemotherapy. Definitely is having the very worst type of toxicity. By empowering this IPSA study, definitely you can see here it is going to incorporate a multiple what I discussed actually for performance status. You can see 76% of patients are like they belong to this performance status 2, and renal dysfunction definitely were there actually here. Age also, like you can see more than 80 years, 31% of patients were there. Like like more than 70 years, almost like you can see that at 73%. This is definitely it's a very encouraging thing. Comorbid patient multiple were there here, and based on this age, performance status, comorbidity, which patient profile you think that benefit like most, like the atezolizumab monotherapy, it definitely is favoring that as per my this one what I is seeing the report. How do you feel actually, Dr. Lokesh?
Yeah, elderly patient who have a lot of comorbidities on polypill, so where they may have pre-existing organ dysfunction. So this set of patient, I think there are clear-cut candidates for a single agent atezolizumab.
Yeah. And Aditya, how do you practice like in your case actually with these factors, like because in a corporate setting actually?
So, if one thing is clear, if a patient is not fit for chemotherapy, what I do offer to them is yes, the most important thing we're looking here for is quality of life, as Dr. Supreet said. So, if a patient is quite keen on having some treatment, and they say that it's okay, doctor, whatever it is, we will try. Then in that space, this fits in very well. So, patients who are not eligible for any chemotherapy and who still want to try something, this is where we can put atezolizumab monotherapy in.
Okay, definitely these kind of patients are there, and even like this patient, there were some people they don't have option because they want to try chemo. Do you want to give chemo or like immunotherapy, Aditya?
So, see, wherever patient is eligible for chemo, we do chemo plus immuno. When patient is not eligible for chemo, only then we do immunomono.
Okay, see, like I try to see that a patient is fit for chemotherapy, that we may do that. Fit means like it may not be classical how you fit for young patient, fit patient. We may modification of weekly schedule or dose the carboplatin, we may use a smaller dose. Also, we may use a single agent, we may use sometimes metronomic also we use it. Sometimes I try to, rather than using the same thing, I try to combine with immunotherapy and try to do it. We don't have data, definitely many of us we are practicing also. Sometimes we may use as immunotherapy with sometimes even radiation also we try to use it. Definitely like, yeah, rather than like a chemotherapy and only like even some LGBT is there, like try to face a lot of toxicity side effect. I try to prefer the immunotherapy, or we may combine like the combination. We may try to use it, or like we may try to use the various other modalities. Sometimes radiation also might try to use it. And that anyone you want to comment on this one, Dr. Hemant? Fit patient, like elderly patient, but not fit as like young patient. Like, do you want to practice immunotherapy alone, or like you want to give chemotherapy and then you're not eligible, then only I try for immunotherapy? How do you want to practice, Hemant?
Yeah, difficult situation. So here probably yes, I would definitely look at PDL1. PDL1 more than 50% straightforward. I would use immunotherapy alone. Recently got PDL1 positivity, and I know that I might underdose the chemotherapy just because he's elder. I would probably then try to stick for accurate dose of immunotherapy instead.
Okay, okay. Because more than 50% will hardly will come across maybe 10 to 15% of patient. I don't think like that's what majority of practice are less than 50% only. Borderline positive or many patient we may not be have a positive patient also. That these are the challenging patients. Fit patient we may use a combination chemo with the immunotherapy. We might practice. Many of us are practicing. Patient is not like Aditya has clearly made it not fit for anything they want to try. Yeah, immunotherapy. Why can't you give that like a atezolizumab? Definitely we can use it wherever feasible you can use it. I think this is my last slide. These are cases like you can see there's situations actually and various like comorbidity, yeah, with the help of our colleagues like the cardiologist, all those we can take the we can take a help of them. We can okay, nothing, okay, no fit, because many of the thing corporate patients are okay, CHH patients are there, they'll tell you after you try something because they are not fit for anything. Yeah, but still this is one of the, we don't have data now, data is there. Yeah, we can give the option immunotherapy also, we can one of the options we can try to use it. This is one thing I wanted to comment. This is like this kind of comorbid patient, even the elderly patient also with IHD, nephropathy, neuropathy is there. There we try to, many of the times we'll try to go for symptom treatment. This is one of the options that we can try. It's coming in guidelines, NCCN guidelines, as you can see here. This is one of the options as a performance status of 3 patient regardless of PD-L1. This is like atezolizumab single agent therapy. Even ESMO guidelines also is included. This recommends that the clinical practice guidelines. You can see this atezolizumab monotherapy that in a patient like a platinum ineligible patient due to performance status more than 2 or age more than 70 years with comorbidity regardless of PD-L1. That's a 1B category is there. Local guidelines, let's you can see that German guidelines also included here. You can see that I think Indian approval also is there. I think I don't know. Like many like Roche they try to use for everyone. Like I think that we don't have data now. Data is there. I think we can start using that. I'll stop here. I'll because of I already we have taken time. I'll hand over like to the event manager to continue. Thanks all the my expert panelists to give a valuable the discussion contribution to the today's event. Thank you.
Thank you, sir.
Thank you.
For the next talk, I would like to invite Dr. Vijay Sima, who is consultant urologist in Shankara Cancer Hospital, Bangalore. Doctor.
Thank you. Can I share my slides?
Yes, sir.
I'll just share my screen. So are you able to see my screen?
Yes, sir.
Yes, sir, we are able to.
Okay. So I thank the organizers, especially Dr. Ravi Tippaswamy sir, for giving me an opportunity to talk on this very interesting topic. Now, we all know that hepatocellular carcinoma is a very difficult disease to treat. And in the so difficult situation, we had one trial, which is the IMbrave 150, which showed that the combination of atezolizumab and bevacizumab showed good outcomes. But it was a one single trial, and we always look at whether is this one set of data corroborated by other sets of data. And in this particular session, I'll be presenting what is the role of real world evidence and how real world evidence supplements the data of IMbrave 150. So real world evidence studies, they complement, but they do not substitute for robustly conducted prospective trials. But prospective trials, irrespective of how well they are conducted, there'll always be data gaps. So for example, particularly in the phase 3 trials, sometimes there will be a issue in enrolling patients who have borderline thrombocytopenia, like platelet count of 90,000, or those who have co-infections with hepatitis B and C and hepatocellular carcinoma, those who have history of bleeding because bevacizumab was used, those who have fibrolamellar HCC, which is not so rare, but often we find this variant, those who have autoimmune diseases which are very mild and well controlled, but are clearly an exclusion criteria for phase 3 trials. Then there is some mixed phenotype HCC cholangiocarcinomas, which are clearly excluded from the clinical trials. Then there are some HIV population, there are some borderline cardiac conditions, and there are some elderly. So there are so many other populations which cannot be tested in prospective trials. However, the IMBRAVE 150 study, which was recently updated with its overall survival, when the initial study was published in the New England Journal of Medicine, the survival was not evaluable. They just reported the 12-month overall survival as a percentage, as a landmark survival percentage. But this update was recently presented, which showed that the median overall survival was clearly, significantly, and meaningfully better in the atezolizumab bevacizumab arm, with a 19.2 months of progression overall survival compared to sorafenib, which had around 13.4 months of progression overall survival. The progression-free survival was also not it was also meaningful, nearly 7 months of progression-free survival compared to 4.5 months, almost 2.5 months of progression-free survival benefit, which was also statistically significant. There is a clear separation of the curves throughout the course. There is no intertwining, and there is no initial rapid decline, etc. So now
Sorry to disturb you, sir. Sir, we
Pardon?
request you to open the camera, sir.
Camera, right. Okay, just 1 second. How do I do it? I have already started since I might have to stop this share. Can I do it later? Yeah, 1 second, 1 second. I think I got it. Okay. Yeah, now you're able to see me? Yeah.
Sir, thank you, sir.
Okay, so real world evidence complements the randomized controlled trial evidence. So we have different set of population from different settings who receive different treatments, often with dose adjustments, and they have different outcomes. And often real world studies may not reach up to the rigor of the randomized controlled trials, but definitely they can confirm whether the RCT results are observed in routine everyday clinical practice, and they complement the insights from more varied settings and varied set of patients, and they give more confidence and improve the quality of the evidence that can ultimately guide routine clinical practice. So this AB Real was the global observational registry of atezolizumab plus bevacizumab in routine clinical practice. It included several sites in US, Europe, and Asia. They excluded child PUC B and C, and those excluded where atezolizumab was not used in first line, and in performance status 2 and 3, even though the A plus B was used, they excluded these patients. The primary objective was to describe the uptake of A plus B in a multinational registry and study the clinical pathological traits associated with prognosis. Had some endpoints like overall survival and objective response rates. This is the baseline characteristics shown in the table. So the median age was 66 years amongst a population of 433, dominated by males. ACOG performance status 0 was 47%, 1 was 53%. BCLCC was majority, that is nearly 70%. Extrahepatic spread present in more than 50% of the patients. AFP more than 100 in almost more than 1/3 of the patients. Child PUC 5 in 64% of the patient, and 6 in 35% of the patient. The ALBI score was 1 in more than 50% and 2 in 45% of the patient. And cirrhosis, which is another disease that coexists with hepatocellular carcinoma, was present in 75% of the patient. Viral etiologies contributed to nearly 65% of the data, while non-viral etiologies contributed to 24% of the data. Portal vein tumor thrombosis, which is an important prognostic factor, was present in 35% of the patient. This is the efficacy summary in this AB real world study. So the median overall survival was 15.74 months, which is quite close to the 19 months overall survival which we saw in the landmark IMBRAVE 150 study. So in a real world setting, the AB real was able to demonstrate a 15.7 months of overall survival, and the median progression-free survival was demonstrated to be 6.9 months. So this real world observational efficacy study confirms that the A plus B regimen is a reproducible, safe, and tolerated regimen in routine clinical practice. This included several centers, even more so in Asia, especially in Japan, Korea, Thailand. And if we see the efficacy and the toxicity were consistent over the study. So a single arm meta-analysis was done of the A plus B efficacy in the real world, which pooled together several studies, particularly from Asia, mainly from Asia, and they were able to show that the pool overall response rate was around 26%, pool complete response rate was on 2%, pool partial response rate was on 23%. So this combination was produced a meaningful response rates, while when we see the adverse effect, it was consistent with what we usually see in the pivotal trials. There was no clear pattern of the improvement in viral and non-viral HCC, while in viral etiologies, there was a tendency for some of the plots in this forest plot to favor the viral etiology. Ultimately, immunotherapy was shown to be efficacious both in the viral studies, which included viral patients with viral etiologies versus those patients who included non-viral liver disease, where even though the magnitude of benefit may not be as good as the viral, but definitely there is no absence of benefit in the non-viral causes of HCC. And even if we see the groups that were non-viral HCC, the overall impression was that immunotherapy had activity both in viral and non-viral. And also it is to be cautioned that these subset analysis are only exploratory and hypothesis generating, and they should not guide our routine clinical practice. So if we see in this viral versus non-viral, eligible patients were compared. There were 323 patients who received Atezo plus Bev for HCC. They were divided into two groups. One had a viral cause of HCC and another had a non-viral cause of HCC. Propensity score was used to eliminate significant differences. For example, the matching was so good that the age and the performance status, the BMI, the etiology of the liver disease, the platelet count, bilirubin and albumin and prothrombin time, which are all important factors which influence treatment, all these were equally balanced. And it was seen that even despite all these equally balanced, there was not a great difference in the viral versus non-viral HCCs, with almost similar complete response, partial response, stable disease, and objective response rates, both in the viral and non-viral. And ultimately, the disease control rate, which we are most worried about when we treat patients with HCC, was similar in both the groups. This is the PFS of patients with viral and non-viral infection. We can see that numerically there is a slightly higher value for the viral infected patients when they are treated with the A plus B regimen versus the non-viral, 7 months versus 6.2 months. However, this is not statistically significant. And similarly, if we see the overall different survival rates at 3, 6, and 12 months, the viral versus not non-viral, again the difference are not significant, and it seems that atezolizumab and bevacizumab, there's no significant difference whether it was a viral or non-viral etiology. Similarly, in those adverse events patients who had different etiologies, the adverse events were not any different. So it was equally distributed between the viral related HCC and the non-viral related HCC. There was no factor which influenced. Now, what about the role of A plus B in those patients who are taste unsuitable, or in those where up to 7 lesions or multiple lesion criteria? So A plus B was studied in these patients. 95 unresectable HCC Japanese patients were enrolled, and it was seen that the overall response rate was 17%. This is control rate of 84.7%. and it produce an objective response rates. So without a significant impact on the hepatic function. Therefore, the A plus B regimen showed favorable therapeutic response with minimal influence on the hepatic function, and it is useful in a therapeutic option in those taste unsuitable patients. So for example, the 7 out or the multiple hepatic lesion cohort. And it is safe and tolerable in these patients where the patients who have cirrhosis, always the patients with hepatocellular carcinoma will be having some degree of liver damage, and it is very important. And we see that most of the adverse effects actually are related to the liver disease rather than the treatment with atezolizumab, with bevacizumab. And in those patients who had child A and B cirrhosis, the safety and tolerability of atezo-bev was seen. And irrespective of child A or B cirrhosis, the overall response rates, the disease control rates, the complete response, partial response, stable disease were all similar. And the median overall survival in first line, where in the background of cirrhosis, was close to 15 months with a median PFS of 6.8 months, again, which is similar to the pivotal IMBRAVE 150 study. And also in those patients who have a tendency to bleed, we can see that either whether it is atezolizumab or bevacizumab, the contribution to grade 3 adverse effects was minimal, and it was not very concerning. There were no new safety signals. And if there was the presence or higher grade of varices, it did not correlate with GI bleeding events because they were generally taken care of preemptively before treatment. So this is the survival curve which shows the outcomes of patients who had child A and child B. Irrespective of the response rates, we can see that survival essentially mirrors the liver function. So therefore, the efficacy and safety of atezo-bev continues to be present, while the survival is actually determined mainly by the background chronic liver disease. So this has been proven by several studies where child A and B had similar efficacy rates and adverse events. What about the use of atezo-bev in those patients who are elderly? These patients are largely excluded from the clinical trials, and we are obviously interested in those patients who how do the elderly fare. So definitely the median progression-free survival and overall survival, in when we compare to the patients who are elderly, it also mirrors the real world evidence, and there is no compromise in the outcomes just because we have a elderly, which is defined as more than 65 years. So 65 years and older had similar survival and safety outcomes compared to younger patients. And atezolizumab, bevacizumab is associated with equal efficacy and tolerability even in those who are more than 65 years. And this also continues to be present even when we see between the etiology of the HCC, whether it's viral or non-viral. So what about comparison with lenvatinib, which is one of the chief competitors of the A plus B regimen? Lenvatinib is among the best TKI that is effective in HCC, and if the patient is usually not eligible for A plus B, we usually use lenvatinib, and in some instances we use atezolizumab plus lenvatinib as a out of indication study. But if we see the difference between A plus B versus lenvatinib, there was the longer PFS in the A plus B group, but however, there was no significant difference in the overall survival, suggesting that there is an effect of crossover, and there is a potential advantage of A plus B and also better safety in the terms of reduced adverse effect when compared to lenvatinib in the treatment of HCC. Such results are also replicated in meta-analysis which compared A plus B versus lenvatinib, which shows that the A plus B performed significantly better compared to lenvatinib in achieving a better overall response rates and a longer progression-free survival without any added adverse effect disadvantage. So the hypertension and GI bleeding was also similar when compared to TKIs and atezolizumab and bevacizumab. To conclude, the real-world study that I have just presented, they complement the evidence from the primary prospective trials in HCC, which has huge global variations regarding the etiology, regarding the treatment, the sequencing, reimbursement. When we have real world evidence, it gives us more confidence to practice when we practice with our patients. And the A+B real global observation study confirms this tolerability and efficacy of A+B. And we also saw in several other cohorts, like the elderly cohort, the viral versus non-viral etiologies, and those patients who have cirrhosis, there also A+B continued to have the same amount of efficacy as was demonstrated in clinical trials. So real world evidence therefore constitutes the basis of prospective future clinical trials, and ultimately the data to practice becomes more robust. So this is the overview of treatment guidelines in advanced HCC. So the first question that is to be asked in a patient of advanced HCC or an intermediate HCC, which is not suitable for loco-regional therapies or progressing on loco-regional therapies, is the patient a candidate for immunotherapy? If the answer to that is no, then the patient goes on TKI. If the answer to that is yes, as happens in majority, then the next question to be asked is whether the patient is at a high risk of GI bleed. And high risk has particularly, we mean higher grade of varices. And if these two factors are not there, meaning that the patient is a candidate for immunotherapy and not a very significant at risk for GI bleed, then atezolizumab with bevacizumab is the first line of choice. This is a concurrence between the ASCO, ESMO, European AASLD, European Society of Study of Liver Disease, American Gastroenterology Association, as well as NCCN. Major bodies all concur with proposing atezolizumab plus bevacizumab as the first line treatment of HCC. So this was my last slide. Thank you so much.
Thank you so much, sir. For the next speaker, I would like to invite Dr. Vijay Kumar Srinivasulu, sir, Senior Consultant, Medical Oncology, Sakra World Hospital, Bengaluru. Sir.
Thank you. Thank you so much for the invitation. Can I please ask the team from the back end to please handle my slides? Yes, hi, thank you. So firstly, at the outset, I'd like to thank Ravi sir for giving me this opportunity to talk about the HER2 horizons and evolving paradigm with tucatinib. And I'm going to be really quick. I'm going to wrap up quickly because I'm the last speaker for the investor session. So primarily to look at it, what tucatinib does, it's a small molecule TKI. So brain has been the sanctuary site. Stasis. Primary reflex pumps in the brain is pushing most of the cytotoxic drugs away, and penetration of these drugs have actually included patients with CNS disease. Next slide, please. So this is a drug which is shown intracranial activity. So if you look at the pharmacokinetics of the drug, it's been significantly different. Tucatinib has a very activity is almost it's a very small molecule, high, and also the engagement ratio, if you look at it, is to comparators like lapatinib or has been significantly lower. Next slide, please. And when you look at the evidence, so this has been the expert. So surprisingly, there was only a 70% concordance when they looked at it in screening for patients with brain metastasis. So the question here which was asked was, is it mandatory to do a MRI brain? So the new recommendation slowly would probably incorporate that. It's Next slide, please. So we're primarily looking at what the evidence is in treating patients who are with asymptomatic brain mets. So next slide, please. Am I audible? Yep. Next slide, please. So what's the evidence for first-line maintenance? So this is a study which was recently discussed in the SAVCS meeting. So this was a study called HER2CLIMB-05. This is in patients. This is a phase 3 placebo-controlled randomized double-blind study, which primarily looked at patients who had no evidence of progression after the THP regime in patients with asymptomatic brain mets or, say, patients with no brain metastasis. They were randomized to tucatinib plus the maintenance standard of the doublet, which is trastuzumab and pertuzumab, versus just the trastuzumab pertuzumab alone, along with the endocrine therapy. So along with the patients who were hormone positive continued to get endocrine therapy. And the primary endpoint was progression-free survival. Next slide, please. So this was our first study which showed that maintenance tucatinib along when added to the trastuzumab pertuzumab showed a significant ratio of 0.64, which says that the reduction in terms of progression there's a 36% reduction in the risk of progression or death with brain metastasis. There was clearly a double. Next slide, please. Next slide, please. So if you look at patients primarily in the brain, there was significantly improvement alone. So that was somewhere between 8.5 months versus 4.3 months. So clearly a doubling of PFS benefit, which is seen primarily in patients with CNS metastasis. So this is again in the first line maintenance setting. Next slide, please. So when we look at the evidence for the second line, so this is no-brainer. We're all very well aware of what HER2CLIMB did. This was one of the largest randomized studies so far for patients with brain metastasis. So these were patients who were heavily pretreated, more than 3 median lines of treatment, and majority of patients actually had received TDM1 along with trastuzumab or pertuzumab, either of it or together. So this was a study where they randomized it to tucatinib with trastuzumab and capecitabine versus just trastuzumab and capecitabine alone. And more than 70% of patients actually had radiation to the brain mets because they were symptomatic. So there were patients who had symptomatic brain mets included in the study. Next slide, please. So the primary endpoint was progression-free survival. So if you look at the intracranial response rate, clearly doubling, you can see a 47% versus 20% on the whole in terms of overall response rate. Next slide, please. So no-brainer, this drug has shown a significant overall survival benefit improvement in patients, especially with brain mets. If you kind of deep dive into the data, there is almost near doubling of your median overall survival which is 12.5 versus 21.6 months with a delta of 9.1 months. So if you look at this, clearly this is practice changing. This is again, we're forgetting the fact that these are patients who are heavily pre-treated with more than 3 lines of treatment in the past, and again having symptomatic brain mets, and this drug is a wonder drug in this particular subgroup. Next slide, please. And when you look at patients with active brain metastasis, the CNS PFS has a delta of around 5.4 months, which shows a significant with a hazard ratio of 0.36. There is a 64% reduction in the risk of CNS progression or death, whereas the overall survival, like I mentioned, near doubling with a hazard ratio of 0.49, and you clearly see a 51% reduction in the risk of death with a like to kind of re-emphasize, these are patients who've had significant brain metastasis. Next slide, please. So the new brain lesion free survival, if you look at it, so clearly there is a possibility to defer the need of next radiation or surgery. So you're trying to avoid one particular potent treatment to these patients because we know what either in the form of SRS or whole brain radiation is its own. We know these are difficult treatments, and there's a lot of cognitive burden which comes in, cognitive impairment which sets in patients who received whole brain RT. So this is a potential prevent, or rather to kind of push their quality of life and defer another potential radiation or surgery kind of a treatment. Next slide, please. So this was primarily another study which looked at in patients, especially in the second line. So this was a study where they looked at it and they showed that it clearly DXT. So if you look at this particular study where they said that patients who received TDXD, they had a median PFS of 5 months and a median overall survival of 13.4 months. So which is DXT tucatinib can be considered in the third line, especially for patients with significant brain mets. Next slide, please. And this combination has also shown a significant overall survival benefit. So this was another abstract in patients with significant burden in our subgroup. We do see a lot of patients who develop leptomeningeal disease. And these patients, when they've received tucatinib, which is a phase 17 patients, they had a median overall survival of 11.9 months, and nearly 41 remained alive at a median follow-up of 17 months. So this is something to be taken into consideration. So in patients with leptomeningeal disease from HER2 positive metastatic breast cancer who were treated with tucatinib, trastuzumab, capecitabine, the median overall survival was nearly 1 year. So which is extremely promising. Next slide, please. So this has been the consensus paper on where we've positioned tucatinib. So pretty much what I'm going to make. So tucatinib has patients with active brain metastasis, and it is the preferred second-line treatment in presence of active brain mets after a triplet combination as per HER2CLIMB. And this was the only study which primarily had more than 100% of patients actually had progressed on pertuzumab in TDM1. And for patients who are requiring whole brain RT, switching an anti-HER2 therapy to tucatinib can significantly help delay loco-regional treatments. And the toxicities across studies, like the diarrhea, the hand-foot syndrome with the triplet, which is trastuzumab, capecitabine, tucatinib, it's important to first try and reduce the dose for capecitabine because this the square, or using a metronomic regime is another alternative. And after progression on TDXT, it's definitely appropriate to use tucatinib with trastuzumab alone is still a strong option to be considered. And when you look at the pharmacokinetics in the brain metastasis, next slide, please. And this has been the ESMO adapted guidelines across subgroups. So if you look at it in the first line setting for patients who are hormone receptor doublet with chemotherapy, and if there is no, along with endocrine therapy until progression, and if there is a contraindication for chemotherapy, you can go for a chemo-free regime where you just do the doublet of trastuzumab with or without pertuzumab and an endocrine therapy. And for the patients who are hormone receptor negative, we have the same regimes again. If there is no contraindication, look at second line. So it's important to know whether patient has active brain met or a stable or unknown or say no brain metastasis. So in the second line, your preferred drug is TDXT or a TDM1. But if patient has active brain metastasis, then the triplet of tucatinib with trastuzumab with capecitabine or TDXT, these are your options. Likewise, in the third line, you just alternate the same. So subsequently, once patients progress on the standard drugs, then you have your novel options like say margetuximab and neratinib plus minus chemotherapy or lapatinib with trastuzumab. This is the updated living guidelines from ESMO, which is from April 2025. Next slide, please. So this is what the NCCN says, pretty much reiterating the same fact that if it's a HER2 positive breast cancer, so if you look at it, it's category 1 to combine, especially in patients who progressed after a trastuzumab plus pertuzumab based regime. You can consider using a tucatinib with trastuzumab and capecitabine, because the primary concern with tucatinib has always been just the toxicities. There is toxicity which has been there, but now we've understood how to handle these toxicity to be in keeping the quality of life as a primary concern. So the other recommendations in HER2 positive breast cancer are you could either go with the TDM1 or neratinib with TDM1, or you have the CAPLAP, the age-old CAPLAP regime, or neratinib with capecitabine, or you can also go with neratinib with paclitaxel. These are CAT2. So the interesting point here, or rather how Destiny Breast 09 is going to change the spectrum, is something which we really have to see, because that's going to be the newer standard of care, especially in the first line HER2 positive metastatic breast cancer, which is basically TDXT plus pertuzumab, where the benefits are significantly stronger, although the OS data is still awaited. So that's we really have to see where tucatinib is going to get positioned over the long run. Next slide, please. So this is my last slide. So the doses for tucatinib, what we use is primarily 300 mg. It should be taken with or without a meal. And most important stuff is that this drug is to be continued regularly. There is no drug holiday with tucatinib, which is combined along with trastuzumab, which is the standard doses where you go with the loading 8 mg followed by 6 mg every 3 weekly, along with capecitabine, where the standard doses has been 1000 mg per meter square taken twice daily. So this is again capecitabine for 2 weeks and then 7-day regimes which we've been following to treat our patients with HER2 positive breast cancer. With this, I would end and happy to take any questions. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Srinivas KG, who is Senior Consultant Medical Oncologist at BHIO Mysore. Dr. Srinivas.
Yeah. Vishal, can you put me the slides, please?
Sharing, sir.
So at the outset, I would like to thank Dr. Ravi and for giving me this opportunity to talk on this topic, and I would like to thank Glenmark for giving me this opportunity to talk on the olaparib in various solid malignancies. Next slide. So the expanding potential of olaparib in management of various solid tumors. So we'll just go through different trials in different organ system. Next slide. So before going to a particular organ system, we'll see what is this PARP, or what we call it as a poly-ADP ribose polymerase. Is essentially as an enzyme which helps in base excision repair. Especially it has a very important role in DNA repair mechanism. So DNA binding domain and the catalytic domain are the two domains this enzyme has, and it has the two types, PARP1 and PARP2, which involves in repair single stranded breaks via base excision repair. And if you will light about the brief about the history, in 1980, Durkaz et al. Proposed PARP1 modulation, which enhances the alkylator chemotherapy effect. Next slide. So if you see the left side, this is the mechanism of action of PARP inhibitor, how these PARP enzymes play a role, and how this when PARP is inhibited by PARP inhibitors like olaparib or rucaparib or niraparib, how do these DNA double-stranded breaks repair mechanism is inflicted, so that the cell will undergo cell death and apoptosis. So, and we essentially understand the role of detecting the HRR, or understanding HRR pathway which is defective in either a BRCA1 or BRCA2 mutated patients, and how is the use of PARP inhibitors to hamper these cells, causing the damage and ultimately the cell death. Next slide. So this is what I was talking about. HRR is not just one mutation; it's the multiple groups of gene mutations, including BRCA1, BRCA2, ATM1, and PAL-B2, RAD51, CHEK2, and many more. But what we essentially understand these are the main types of mutations which are covered under HRR small panel, which we do in our routine day-to-day practice. And these are some of the gene mutations which are FDA approved through Foundation on CDX and other diagnostic modalities. Next slide. So this is the next slide. So there is a synergistic effect which we know that it enhances the chemotherapy effectiveness in preclinical models, and DNA methylating agents induce DNA breaks requiring base excision repair, and the PARP inhibitors negates the resistance causing DNA breaks, and the homologous recombination repair is overwhelmed by double strand breaks leading to cell death. Next slide. Next slide. So let us go to the individual organ system now. So what has been potentially evaluated, extensively studied is in ovarian cancer. We all know that Solo One revolutionized the way we look at the PARP inhibitors in ovarian cancer management today. So Solo One showed that when we give the olaparib in a maintenance time, I mean, for a newly diagnosed BRCA mutated patients who after completing their adjuvant platinum therapy, if you give a maintenance olaparib, it can give a median PFS of 56 months versus 13.8 months with hazards of 0.30, very gratifying hazard ratio what we get. And this has changed the whole outlook of ovarian cancer management. Those were the days when only people used to talk about platinum sensitivity, platinum resistance, the prognosis depending on their platinum sensitivity and platinum refractory and platinum failures. So this has changed the whole outlook how we manage ovarian cancer, especially when they are BRCA mutated. Uh, and subsequently, we had OLA study where it showed that adding an anti-VEGF to an olaparib in a newly diagnosed who are HRD positive after platinum therapy again showed a wonderful hazard ratio of 0.33. But Paulo looked essentially into HRD positivity rather than individual BRCA. Of course, BRCA mutated were also equally benefited in that subgroups. But mainly, essentially, what it looked for was HRD positivity was the eligibility criteria to enter into the trial. So people who are HRD positive were essentially had a exposure of olaparib with bev. Again, very gratifying HR of 0.33 was shown in the study. Again, changed the whole outlook of ovarian cancer patients. The beauty of this Paulo was around 20% of our patients who are suboptimally cytoreduced also got a significant benefit with olaparib and anti-VEGF. So then subsequently we had a Prima. Again, this was the on niraparib again for newly diagnosed, but it was regardless of biomarkers showing a benefit of hazard ratio of 0.43, and Nova addressing niraparib in recurrent and platinum setting, and Ariel for rucaparib in recurrent platinum sensitive ovarian cancer. Next slide. So testing criteria for ovarian cancer susceptible genes, this is the NCCN criteria for mutation testing in ovarian cancer. Specifically, we look for these typical mutations like ATM, BRCA1, BRCA2, BRIP1, Lynch syndrome genes, MLH1, MSH2, PAL-B2, RAD51. So testing is clinically indicated in those situations as alluded to in this slide. Next slide. So as I told you, Paula was the trial which showed that it was a multicentric randomized double-blind phase 3 trial randomizing newly diagnosed ovarian cancer patients, stage 3 or 4 with high-grade serous or endometrioid ovarian primary peritoneal or fallopian tube, completing their platinum taxane combination. Then they were randomized to either olaparib with bevacizumab or bevacizumab alone as per our ICON 7 or ICON 8 data. Bevacizumab is also a potentially used maintenance strategy if especially we also do this kind of anti-VEGF maintenance strategy even in HRD negative and BRCA negative patients, of course, in our day-to-day practice. But this essentially looked for HRD, this one, positivity. They are looked into, and regardless of surgical outcomes. That is something very important, what we need to understand. And there are a few situations where we come across a gynecologist would have done a surgery where they would have done a suboptimal cytoreduction, doing a proper cytoreductive surgery. Again, may be a challenging situation for us in a day-to-day practice. So, practically speaking, this is the trial which actually um, uh, correlates with our routine day-to-day practice situation, where we can have an option of giving an anti-VEGF with PARP inhibitor. This is a trial which showed that this was a randomized study. Next slide. So the primary endpoint of progression-free survival, as you can see in HRD positive subgroup, 46.8 months, nearly 4 years of PFS with olaparib plus BEV, also 17 months with bevacizumab alone, 59% reduction in risk of disease or death, suggesting that hazards of 0.41, very, very gratifying hazard ratio of 0.4 was seen in this PAOLA-1 trial. Remarkable landmark trial, I can say. Next slide. So that data suggests that addition of olaparib to BEV enhances the potential for cure in substantial proportion of patients with HRD positive tumors, including those even without a BRCA. If they are, what I mean to say is, the patient, if she is a BRCA negative, but still if the patient is HRD positive, still the hazards are very impressive, and that patient will be eligible for olaparib with BEV regime. Next slide. So this is again the OS data showing a very impressive OS benefit in HRD positive and BRCA mutated subgroups. Next slide. Next slide. So no, just go back. So what we also understand, who are not the eligible patients or who are not the appropriate patients for this regime. So if you see the HRD negative tumors, if you see on the right side, absolutely there is a very, very modest or no minimal or no benefit in HRD negative groups, suggesting that if the patient is really HRD negative, they may not get a benefit of adding this regime as a maintenance strategy, rather than bevacizumab alone may be a good maintenance strategy for these HRD negative tumor patients. So at 7 years, overall survival was approximately 2/3, that is 67% of patients with olaparib and 47% with placebo. Next slide. Again, this is SOLAR-2 trial. Next slide. Addressing patients. This is a randomized control trial, phase 3 trial, which was done across 123 medical centers in 16 countries. Next slide. So patients with platinum sensitive relapse serous ovarian cancer having a germline BRCA1 and 2. So this is, we are talking about relapsed patients who are treated with more than 2 prior lines of platinum based therapy with complete or partial CR, and that time dependent secondary endpoints. The primary endpoint was investigator assessed PFS, and time dependent secondary endpoints were OS, time to first subsequent therapy, time to second subsequent therapy, and so on. Next slide. So if you look at the overall survival again, it was median OS was 51.7 months versus 38.8. Hazards of 0.75 was seen in this solo trial, and adjusted for subsequent PARP inhibitor. If you can see again the median OS 51.7 versus 35.4 with hazards of 0.56, which is very significant. Next slide. Even if you see the time to subsequent therapy, the time to first subsequent therapy was 27.4 months in olaparib was a 7.2 months, which is even one third, not even one third of that. So hazards of 0.37 was seen. So suggesting that olaparib arm did very well in this group of patients. Next slide. So at this time, the preferred chemotherapy regime is paclitaxel given every 3 weeks, 6 cycles given for stage 3 and 4 tumor. And if the patients are having this one BRCA PARP inhibitors currently used are the maintenance as a maintenance. And there are 3 PARP inhibitors: olaparib, niraparib, rucaparib, all are approved. So olaparib alone can be given for 2 years. Olaparib plus bev together can be given up to 15 months, with olaparib continued up to 2 years in total. Next slide. Next slide. So then let us see what is the evidence we have in prostate malignancies. So actually, initially the first PARP inhibitor in prostate was actually the rucaparib, which got an accelerated approval in patients with BRCA mutated metastatic CRPC with prior treatment androgen receptor therapy and taxanes. So then in 2023, olaparib with abiraterone and prednisolone was approved for patients with deleterious or suspected deleterious BRCA mutated metastatic CRPC. Then August 11, 2023, niraparib was a fixed dose combination and abiraterone asset was with prednisone was approved. Next slide. So this is the trial, PROFOUND trial, which looked into metastatic CRPC patients who progressed on hormonal therapy, conventional hormonal drugs. Cohort A had patients with at least one alteration in BRCA1 or 2 or ATM gene, and cohort B was alteration in any of other 12 other pre-specified genes. So they were randomized into 2:1 fashion. So the eligibility criteria for patient inclusion was HRR gene alteration rather, and the primary endpoint was imaging based progression-free survival assessed by an independent review committee. Next slide. So if you see the main objective was overall survival analysis, objective response rate, PSA response, and circulating tumor cells conversion. So Foundation 1 CDXD next generation sequencing was the test used to prospectively identify patients with qualifying deleterious or suspected deletion alteration in at least one of the 15 pre-specified so-called HRR genes. Next slide. So this go back one slide, just go back. No. Previous slide. So cohort A, they were randomized into olaparib 300 mg BD and versus control. Around 162 patients were on olaparib arm and 83 patients were in control arm. And similarly, cohort B, 94 patients were in olaparib arm and 48 patients in control arm. Next slide. So if you can see, the PROFOUND met its primary endpoint, having a significant benefit in patients with olaparib compared to the control group. Next slide. So the radiological progression-free survival was median of 7.39 months, was 3.55 months. The 12 months PFS was 28%, was 9%, which is almost tripled in olaparib group. Hazard ratio of 0.34 was seen, which is very significant. And if you see the overall survival, it was 18.5 months versus 15 months with a hazard ratio of 0.64. Next slide. Again, if you see the image based progression-free survival in both cohort A and B, the radiological progression-free survival was 5.8 versus 3.5 months, was a hazard ratio of 0.49 was seen, and the overall survival 17 months versus 14.2 months, hazard ratio of 0.67 was seen in this trial. Next slide. So another trial called PROPEL, which is a randomized double-blind multi-center phase 3 study trying olaparib plus abiraterone relative to placebo plus abiraterone as first-line therapy in men with metastatic CRPC patients. The primary endpoint was radiological progression-free survival by investigator assessment, and the secondary endpoint was time to first subsequent therapy or death, time to brain progression and overall survival. They were randomized to olaparib plus abiraterone versus abiraterone alone. Next slide. So these were the inclusion criteria. Next slide. So as you can see, the median IBPFS by investigator assessment was significantly longer in olaparib with abiraterone arm, 24.8 months for an and versus 16.6 months for abiraterone alone group. So again, hazard ratio of 0.66 was seen, which is very statistically significant, suggesting that there is a significant benefit of adding olaparib with abiraterone in this group. Next slide. Just go back. So an exploratory subgroup analysis in 85 patients with BRCA mutated, the median PFS was not reached in the olaparib with abiraterone arm compared to 8 months for placebo. The OS hazard ratio of 0.30 was seen. The median OS of 42 months with olaparib plus abiraterone and 34.7 months with abiraterone alone. Again, the hazards of 0.81 was seen in this study. Next slide. So olaparib as monotherapy was also tried. TOPA-B, which is a phase 2 randomized trial, as trying PARP inhibitor of olaparib for metastatic CRPC with DNA damage repair alterations, progress after first line taxane therapy. Majority also were post androgen receptor in which are like abiraterone, enzalutamide was given to these kind of patients. They were randomized to a 300 mg BD versus 400 mg BD is a dose study in this monotherapy study. Next slide. So if you see the response rate, 54% when the patient received 400 mg olaparib versus 37% if it is 300 mg. But we have some toxicity issues because patients in our clinical practice, they don't tolerate higher doses. But what I was essentially seen was the median PFS of 5.4 months was seen. And if you see the BRCA1 and 2 alteration, the response were much higher, 80%. But compared to ATM alterations, which was to the tune of 25%, or rather CDK12 alteration, it is 20 to 25%. So BRCA1 and 2 alteration were the patients who had the highest overall response rates in this study. Next slide. So coming to breast cancer, we have now 2 trials, Olympiad and Olympia. Next slide. Next slide. So coming to Olympiad, a randomized open label phase 3 trial, where olaparib monotherapy was compared with standard therapy in patients with BRCA mutated and HER2 negative patients. The primary endpoint being progression-free survival and secondary endpoint being safety outcomes, overall survival and objective response rate. Next slide. The eligibility patients were BRCA mutated germline. So they were, if you can see the curves, the olaparib arm had a good PFS, or the hazards of 0.58 was seen. However, next slide. There was no statistical significant improvement in OS with olaparib compared to treatment of physician choice. The possibility of meaningful OS benefit among patients who had not received chemotherapy for first-line metastatic breast cancer may be the reason. So to address this issue, there was a phase 3 data I'm going to show you later. Next slide. But in first line MBC, the median OS was longer for olaparib than TPS, 22.6 months, 14.7 months. The hazard ratio of 0.55 was seen, and the 3-year survival was 40% for olaparib versus 12.8% for treatment of physician choice. This was seen in an extended follow-up study. Next slide. So dose reduction was most commonly due to anemia in the olaparib group, which is actually we also see the same thing in a clinical practice. There is 35 to 40% of our patients will have grade 2 or grade 3 anemias, where they may require some kind of
Sorry to disturb you, sir.
intervention required. Next slide. So this is another study,
Hello.
Olympia study, which was studied for in an adjuvant setting, a phase 3 double-blind trial in HER2 negative breast patients who are having a germline BRCA1 and BRCA2, and HER2 negativity has to be seen, and they should have a germline BRCA positivity patients. The primary endpoint was IDFS, and the secondary endpoint was OS and DDFS. Next slide. So they were randomized to olaparib versus placebo plus endocrine therapy. So next slide. If you see the invasive disease-free survival, next previous slide, please. So the primary endpoint was met. The IDFS was significantly better in olaparib group. So in this pre-specified interim analysis, adjuvant olaparib significantly improved IDFS versus placebo, with the statistical was significant crossing early reporting efficacy. Next slide.
Sir, sorry to disturb you.
Yeah.
So we request you to conclude the session, sir.
Yeah. Next, I think one last slide is left, I believe.
Okay, sure, sir.
So this is the NCCN guideline for use of PARP inhibitors in breast cancer patients, irrespective of actually ERPR positive or ERPR negative. If they are BRCA germline BRCA mutated patients, definitely an adjuvant PARP inhibitor would be beneficial. Next slide. So safety profile, as I told you, anemia is the most common side adverse effect what we see. Neutropenia and thrombocytopenia, grade 3 is around 25 to 30%, and we all know how to manage it. So the proportion of patients and the corresponding 95% interval was calculated in this study. Next slide. These are some of the hematological adverse effects with various drugs. Next slide. So thank you so much for opportunity.
Yeah, thank you, Dr. Srinivas. That was a wonderful talk. And at the outset, I thank all the esteemed faculty for taking time in their busy schedule and completing these wonderful sessions. And I thank the sponsors, Zydus, AstraZeneca, Roche, Eisai, Adley for giving this opportunity. So with this, I think we will conclude the session, and I thank Horizon for conducting this session wonderfully. I think with this, we are happy to conclude. Thank you all.
Thank you, sir. Thank you, everyone, for wonderful talk. Good night, everyone.
Yeah,
Technical
good
team,
night.
please.